there are two laws which have been changed, and we are going to continue to have a discussion on late lines gestation. So that will be our agenda for today. And today's first talk is on approach to non-invasive ventilation. And with advances in neonatology, there have been substantial improvement in survival. Substantial improvement in. It's too loud. There has been substantial improvement in survival of more preterm babies, and the survival of these babies has increased. And yeah. You will switch off now? Okay. So he switched off the mic. No, he switched off the mic, sir. So even if I speak, it will be recording there. We cannot get output through the mic. So that is okay. He's telling there is overlap from that. So what is a major bronchopulmonary dysplasia is the major complication we find in these extreme preterm babies who are surviving. So we are looking at various options to prevent this bronchopulmonary dysplasia, and that is where NIV's role has come into play. And why it's because the major pathogenesis of BPD is multifactorial, and we know that ventilator induced barotrauma and volute trauma and premature lung are the major factors that cause bronchopulmonary dysplasia in preterm babies. So this is a recent study that was published in archives, and you can see that as the gestational age increases, the survival of babies is increasing. But look at the BPD, the black bars represent BPD, and you can see that at 27 weeks almost there is 50% incidence of BPD in these preterm babies. So any baby, any preterm baby with respiratory distress syndrome, we ventilate, then there is ventilator induced lung injury that is resulting in BPD. So once NIV comes into play, we can prevent this ventilator induced lung injury and look at reducing the incidence of BPD. So comparing NIV, CPAP is one of the most commonly used modality of non-invasive ventilation, and when we compare CPAP with intubation, this is one systematic review and meta-analysis, and you can see that the result is favoring nasal CPAP, the diamond, that is the result, and it is favoring nasal CPAP. And for one additional infant, we could survive one additional infant to 36 weeks without BPD for every 25 babies if they are treated with CPAP rather than non-invasive ventilation. So non-invasive ventilation is very important in reducing the incidence of BPD, thus improving the intact survival of these preterm babies. So what is non-invasive ventilation? It refers to providing positive pressure respiratory support to any neonate without an endotracheal tube. So the difference between mechanical ventilation and non-invasive ventilation is there is the absence of endotracheal tube when we ventilate or we give respiratory support to a baby through non-invasive ventilation. So what are the various modalities of non-invasive ventilation that we have? They can be broadly divided into constant airway pressure and variable airway pressure devices. And coming to constant airway pressure devices, we have CPAP, HFNC and low flow oxygen. And coming to variable airway pressure devices, we have NIPPV, BiPAP and nasal high frequency ventilation. So among these modalities, only HFNC and low flow oxygen do not have a pressure generator. That is, we are not going to, suppose you start a baby on HFNC or low flow oxygen, you are not going to give any pressure, any set pressure. We don't know how much pressure is being delivered to the baby's lungs. Whereas CPAP, NIPPV and BiPAP, CPAP, NIPPV and BiPAP, we have pressure generators, and for bubble CPAP, it is the bubble chamber which is the pressure generator, and for rest all, it is the machine that we are using, whether it is a ventilator or a standalone BiPAP machine or an NIPPV. And for HFNC, we do not have any pressure generator. It is just flow, and it could give some pressure, but we do not know exactly how much pressure we are going to give to the baby. So how do we deliver these non-invasive ventilation through various modalities is through various interfaces. So whether it is CPAP, NIPPV or BiPAP, the interfaces remain the same. So it is basically nasal prongs, RAMS cannula, nasal mask, and OptiFlow cannula for heated humidified high flow nasal cannula. And for variable flow CPAP and BiPAP, we have a different interface where the expiratory limb is open to air. So that is where our Bernoulli's effect and the Coanda effect comes into play, and that will be explained in your next stations in detail. So now that we know what modalities of NIV we have, how we give them, what are the indications to start NIV? So for any neonate to give respiratory support, I think basically there are only 3 indications. So it is for respiratory distress, you start either for apnea or as a post-extubation modality. So when it is respiratory distress, you need to have a structured scoring system to see the severity of respiratory distress the baby is having, and you score them through Downey score or Silverman-Anderson score, and these will be dealt in the next talk in detail. And other than clinical assessment of respiratory distress scoring, we look at blood gases to look for respiratory acidosis and oxygen requirement. So these are the 3 ways by which we score the respiratory distress in these babies to start and decide on which modality of NIV we want to give. And the next one is apnea. So severity of apnea, how severe the apnea is, whether the baby requires non-invasive ventilation or any other mode of respiratory support or not. So for apneas, it depends on how many episodes of apnea the baby is having, or whether the apnea is severe enough to be giving positive pressure ventilation. Then we will have to look at starting respiratory support for these babies. And the next one is once you are extubating the baby from mechanical ventilation. As you are extubating a baby, then CPAP or any non-invasive ventilation modality can be a choice to wean off the baby from mechanical ventilation to the room air. So it is the stopgap between being off respiratory support completely and mechanical ventilation. So what are the physiological effects of these modalities of non-invasive ventilation? I think all of them act through mostly the same ways. So except that HFNC will differ in pressure generation when compared to all this. So the first one is they prevent atelectasis, they increase the functional residual capacity and improved compliance of the lung, and this will help us in recruiting additional alveoli and splints the airways, thus reducing the distress or grunting or retractions, whatever the baby is having. Then the next one is they decrease obstructive and mixed apnea by splinting airways and diaphragm, stabilizing the chest wall and regularizing the respiratory rate, and that is why they become a choice of respiratory support in babies with apneas. They increase improved oxygenation through decreasing pulmonary vascular resistance. They decrease thoraco-abdominal asynchrony by splinting the airways and diaphragm again. And they decrease intrapulmonary shunting by recruiting additional alveoli and decreasing the pulmonary vascular resistance. And conservation of surfactant happens by recruiting this alveoli and improving the pulmonary blood flow and oxygenation. And also there is evidence that there is improved lung growth when you apply CPAP to these babies by stretching the lung tissue. So these are the various beneficial and physiological effects that we have with non-invasive ventilation. And here is a video that you can see where the baby has distress and grunting. I don't know if you can hear on the video, but then this grunting will disappear once the baby was started on CPAP. So what happens here, CPAP is helping in increasing the functional residual capacity. When there is reduced functional residual capacity, baby tends to breathe against these closed vocal cords and there is grunting. So what happens when you apply CPAP, there is increased FRC and the grunt decreases once you apply CPAP. So what are the various choices of different modes of NIV that we have is CPAP, which is most commonly used. I think in every unit nowadays CPAP is used. And the next one is NIPPV or BiPAP. Here there is variable airway pressure That is, in a CPAP there is a continuous constant pressure that is applied throughout the respiratory cycle, whereas in NIPPV or BiPAP there is variable pressures that are delivered throughout the respiratory cycle. But how NIPPV differs, like NIPPV also, like mechanical ventilation, we set PWP and PIP, but how it differs from mechanical ventilation is the pressure is not delivered directly to the alveoli, it is at the nasal level, so there is so much amount of leak and loss of pressure. So definitely whatever the pressure that we are delivering to the alveoli is below the set pressures that we are keeping. So what basically NIPPV does is not like mechanical ventilation, but these variable pressures, they help us in augmenting, that is increasing the map that we are delivering to the babies. So in a CPAP, suppose you set a PWP of 6, then you are delivering a map of 6, but suppose in NIPPV or BiPAP, when you set 2 different pressures, then in one part of the respiratory cycle there is increased pressure that you are delivering to the alveoli. So the map that we are delivering to the lungs is increased or augmented with these variable airway pressures. And the next one is heated humidified high flow nasal cannula. Like I told, we discussed before, there is no pressure generator here. We don't know how much pressure we are going to give. But here, if the baby has some amount of distress, just mild tachypnea with increasing oxygen requirement, then you can choose this as the mode where you give flow and blended oxygen, which is heated and humidified. And nasal high frequency ventilation, it is a newer mode, we don't have adequate evidence, but then it is one modality where you give high frequency ventilation through the nasal interface. Then low flow oxygen, any baby has distress, we tend to put the baby on low flow oxygen, but when the baby has distress, we should not give just low flow oxygen to the baby, because distress is not just oxygen requirement, it is pressure requirement. So you need some amount of pressure that is to be generated to help tackle with this respiratory distress that the baby has. And moreover, the oxygen is also not blended here, so there is no point in giving 100% oxygen FiO2 for a baby without looking at saturations. So coming to the evidence of efficacy of non-invasive respiratory support various modalities, this is the recent systematic review and meta-analysis done by Veeraraghavan et al. He is actually a good friend. And here they have looked at various modalities of non-invasive ventilation that were used as primary respiratory support. This came as a 2-part network meta-analysis where they looked at primary respiratory support and as post-extubation modality. And as primary respiratory support, NIPPV definitely fared better when compared to CPAP, HFNC, BiPAP and other modalities of non-invasive ventilation with respect to decreasing the need for invasive mechanical ventilation or treatment failure, then complications like reduced air leaks and lesser incidence of BPD or mortality. So when it came to post-extubation, synchronized NIPPV fared better when it compared to others, but then there was no difference in BPD when compared to synchronized and non-synchronized or CPAP when you are using it as a post-extubation modality. So as primary respiratory support, NIPPV definitely fares better compared to CPAP and HFNC, and as a post-extubation, if you have synchronized NIPPV available, then that should be the modality of choice. But then whatever respiratory support, whatever form of non-invasive respiratory support you start, you need to keep physically, clinically assessing the baby, and you can grade up your respiratory support or grade down the modality of NIV that is available to you. So there are only 3 indications that we discussed: primary respiratory support or apnea and post-extubation. Post-extubation, we need to remember that NIPPV or these variable airway pressures fare better when compared to constant pressure, that is CPAP, but all the studies included extreme preterm infants or VLBW babies. So when you are extubating a preterm baby who is a VLBW or extreme preterm, then we need to remember that you can go to NIPPV as the first choice when you are extubating the baby from mechanical ventilation. And when it is a term baby who has just a minimal amount of distress or grunting or oxygen requirement, then you can choose CPAP or HFNC as initial modalities. And once you see that the baby is not coping with CPAP or the work is not being done with HFNC, then you can upgrade to NIPPV and finally look at what is happening and then also resort to invasive ventilation. So when you want to grade up these respiratory supports or look for other modalities, what is it that we need to understand is we need to understand what is failure of that modality. So when do you know that the baby has failed that particular mode of NIV. So for that you need to know what is failure. So what indicates failure is either you look at your blood gases which are showing respiratory acidosis, or your clinical scoring systems like Downey score and Silverman-Anderson score, where the work of breathing is increasing. That is, it's not, even after you have started the baby on CPAP, the score has remained the same, or for that matter it is worsening and score is increasing. Then you need to you need to grade up your NIV. And the next one is whether the recurrent apneas with desaturation and brady have settled down or not once you started your modality. So looking at these three things, you know whether the modality is failing or it is in keeping or improving the baby, and then you can decide about changing over the NIV modality that you are using for the baby. So we'll just look at a case scenario. See, this is a baby born at 36 weeks gestational age in view of preterm onset of labor by vaginal delivery, cried immediately after birth. Baby was referred to your hospital with complaints of tachypnea. So once when you examine the baby, baby had grunting, respiratory rate of 66 with retractions, SpO2 in room air was 88. Downey score is 4/10. What will you start for this baby? What will be your choice of non-invasive ventilation? So this baby has grunting, minimal tachypnea, and the saturations were 88, and this is a fairly bigger baby. So definitely you will not start HFNC because you need some amount of pressure generation here because the baby is grunting already. So next mode, what will you start? Will you choose CPAP or NIPPV? Obviously we will choose CPAP because this is a bigger baby, probably a minimal amount of pressure support with a constant airway pressure will be better for this baby. So next you can see this is a 32-weeker by emergency cesarean section in view of severe PIH. Baby's birth weight is 1.1 kilos. It is an IUGR baby. So cried immediately after birth. SpO2 in room air is 94. Respiratory rate is 68. No retractions or grunting. So baby has just a minimal tachypnea. So what modality of NIV you will want to start in this baby? There is no grunting. You don't want much pressure support. This baby is fairly maintaining saturation. So you can just try HFNC. So this is another baby C who is 26 weeks preterm, intubated for poor respiratory efforts in the delivery room, had severe RDS, required 3 doses of surfactant, then extubated to CPAP on day 3 of life. So post extubation, baby developed repeated episodes of apnea requiring bag and mask ventilation on 2 occasions. So this means that CPAP modality as post extubation NIV is failing because baby is having 2 episodes of apnea requiring bag and mask ventilation. So in this baby, what we would have done differently? Because this is an extremely preterm baby, so baby is extubated from mechanical ventilation after giving surfactant. Probably we could have tried NIPPV instead of CPAP. Okay. So this baby we will increase CPAP or intubate and ventilate or start NIPPV. Obviously we will try NIPPV, that is we will grade up from CPAP to NIPPV before we think about intubating the baby and ventilating the baby again. So what determines the success of NIV is not just the modality of choice that we do. Of course it comes first, it should be the right choice of non-invasive ventilation. Suppose the baby is requiring pressure support, there is no point in starting the baby on HFNC. So appropriate interface, this is as important as choosing the right mode. If your interface there is a leak, there is a smaller size, there is a bigger size, then there is no point. So you need to have an appropriate interface for the modality of NIV that we choose. Then optimal humidification, which plays a very, very important role in augmenting the function of the modality of NIV that we are choosing. Then adjuvant therapies like surfactant and caffeine, like when we want to give surfactant, when we have to add caffeine. So adjuvant therapies are important. Then you need to have adequate and structured monitoring. It's not just coming and seeing the baby thrice a day, twice a day. You need to have continuous monitoring. You need to make it structured. So you need to have monitoring charts where you can think about how the baby is improving, how the baby is not improving, or why the baby is worsening. You can get a point of view once you look at continuous monitoring rather than one point monitoring that you see. And you need to look at whether there is any failure of equipment. Sometimes even failure of equipment will result in failure of modality of that NIV that we have started. And then supportive care plays also a very important role. That is, these babies generally are not very comfortable because there is some amount of pain or there might be some injury. So you need to look at developmentally supportive care with pain management and nutrition. Though I have written last, the most important thing is nursing care, because we are just choosing the modality, but nurses are the ones who are actually fixing the circuit interface, looking at how the baby is comfortable, and they are the ones who are, you know, who are the point of contact with the baby continuously, and they are the ones who are going to pick up first when the baby is failing the modality. So nursing care is very, very important. Thank you.
Importance of NIV. We next have speaker Dr. Srinivas Murthy. He'll speak about assessment of respiratory distress, initiation of CPAP, the progress and the so Dr. Srinivas Murthy sir heads the unit at JSS Medical College, Mysore. So I think most of us people who are working in the field of innovation, I think Srinivas Murthy sir is a big name there. He's got a patent in his name. After doing his MD, he also has a fellowship training from McMaster's University, Canada, and he has actually devised a new type of laryngoscope. So he's got a patent as well. So he works continuously in the innovative field, as well as he does a lot of work in the field of respiratory distress in the term. So I think in one of his talks, I think you can see they have devised a new score and have compared that score to the existing scores. They've also devised early detection of jaundice by looking at stool color. Sir is actually quite busy in the research arena. So let's hear from him the new score as well as the current existing way to assess respiratory distress. Over to you, Srinivas sir.
Good morning, everyone. Thank you, Abhishek, for such a wonderful introduction. I'm not that a big person, honestly. Anyway, let us get on to the business quickly. The last part, the focus of being which has been so I'm going to restrict myself. Am I audible? I think I am quite loud in that sense, right? So let us go to the previous slide. Yeah. So I'm going to restrict my talk to just assessment of respiratory distress and how to initiate a respiratory support. I think there is the problem that all of us encounter, whether you are in PHC, whether you are in a taluka hospital, district hospital, a level 3 neonatology unit, doesn't matter. You receive a baby who is having respiratory distress, then you have to decide what you have to do. Let us see what we can do. Fine. Next slide, please. Thank you. So whenever we are talking about assessment of respiratory distress, think of these things. We have to assess in the two different domains. One is in the clinical domain, one is in the functional domain. They are not mutually exclusive, they are overlapping, but just for the sake of ease, I have made it as a two different sort of limbs, so that it will help us to initiate the support in an appropriate way. Next one, please. So let us know what respiratory distress means in newborns. Generally, we all know that sucking of the chest inside, that is the chest retraction is the respiratory distress, but that is not all. Tachypnea is also respiratory distress, grunt, use of accessory muscles, wheeze, and not to forget this part, which is generally sort of, I would say, overlooked as respiratory distress, is also indicative of a respiratory illness inside, and for the sake of management, we should consider it as part of respiratory distress. For example, irregular breathing, baby could be apneic. Baby could be apneic because of exhaustion. So we should not consider that baby is reasonably well, because actually is on the other end of the spectrum. And if there is oxygen requirement which is going up and up, that might be one way the babies actually show that their respiratory illness is getting worsened. And cyanosis, I don't think that we should say cyanosis in this age, because we have SpO2 monitoring. Next slide, please. Okay, these are standard definitions, all of you know. I just don't want to take too much time about it. But all that I want you to understand is, if there is only tachypnea, more likely pathology inside is a restrictive lung, which means to say there is difficulty in expansion of the lung. Either it is due to RDS or pneumonia, or pleural effusion, whatever it is, there is difficulty in expanding the lung. That's what it means. Sorry. So one other thing I just wanted to highlight here is, in patients with central nervous system infections, metabolic illness, they tend to have little bit heavier breathing. The rate will be marginally increased, not very much, but it is the amplitude which will be very high. They are called as hyperapnea. Then you should understand that probably you are dealing with non-respiratory cause as well. It is not hard and fast, but by and large, if there is a small amplitude fast breathing, it indicates pulmonary pathology which is of restrictive nature. Whereas if the baby is having a little bit heavyish breathing and marginally increased rate, then probably you are dealing with either CNS or metabolic or something of that sort. Next slide please. So chest retraction, we all know, we are very familiar with all these things. Next. Okay, whenever there is chest retraction, what it means, baby is trying to expand the lung, but he or she has failed, and that's why she is sucking the chest inside. So it is a waste of the work that has been generated in the baby's system. So more the chest retraction, more is the wasted work of breathing. Next slide please. So grunt is one of the nature's gift to maintain FRC. Whenever there is a restrictive lung, the alveoli tend to become smallish, they become sticky, and they can become very stiff, very difficult to expand. So by generating internal PEEP, by closing the glottis at the end of expiration, baby try to maintain that FRC so that the lung will not, or the alveoli will not completely collapse. So that's a gift given by the nature, but it indicates that we need to act at this point of time, otherwise the baby is going to get exhausted. So here again, some babies, when they are having a lot of pain or when they are misery, they moan, sort of thing. So do not confuse that one with grunt. Grunt is a very typical sound where that sort of thing will be there, whereas in moaning, which might sometimes sound similar, might be confusing. It indicates that baby is in pain or misery or something like that. Next slide please. So I think all of us are very, very familiar with Silverman scoring. We all know this one, right? I don't want to elaborate on this. And we know that score of more than 6 is impending respiratory failure, more than 4 is something to worry about. And this score depends entirely on our observation of the baby, like chest retraction and nasal flaring and expiratory grunt. We don't even use the stethoscope much here, except for the expiratory grunt, which is in the one. Next one please. Next slide. Yeah. Can you switch on the videos one after the other? A video play madakagattama. There is a video here. Yeah. I don't know whether you can see it properly. These are 3 different babies who has chest retraction. I just wanted you to see that one and see whether you can really make any difference out of it. I couldn't make, but I don't know whether you can make it. Just play one video after the other. I don't know how many of you could appreciate the difference between the retractions, and can you really gauge the difference of the illness or the magnitude of the illness in this baby? I don't think it's very difficult, because chest retraction is a manifestation which is entirely subjective for that given baby. For a given amount of disease, it is not true that the retraction is proportional. So just depending on the chest retraction might be sometimes misleading us. So that is the reason why I have put these videos. Next slide please. So according to the standard protocol, if the Silverman score is more than 4, we need to act on that. But again, I want to emphasize here, even if the chest retraction is not there, if there is irregular breathing, apnea, cyanosis or low saturation, we need to act. Let us know what to act later. Next slide please. So there are a lot of advantages, easy to do, but having said that, now we have progressed a lot ahead. So I don't think that Silverman score is that great tool to use at this point of time. Next. There was an improvement over Silverman score with Downey score. There is one more modified Downey score where this 40% oxygen is taken off and any requirement of oxygen is included there. This is little bit more advanced. The reason I am telling this is, see, they have considered effect of treatment as one of the tool to assess. If you see, after giving oxygen, does the cyanosis improve or whatever. So this was a very conscious attempt in 1970 where they thought that effect of treatment is also an indicator of the severity of the illness, which made a lot of sense. So with this Downer score was later modified where this 40% oxygen was removed and giving any oxygen was sort of included in this column. Next line please. Again these scores are very similar, less than 4 you are a little bit eased off, more than 4 you are worried, and more than 6 is impending failure, more than 7 is impending failure, right. So again the same thing, if the Down score is more than 4 we need to act. So once the baby comes to you, if the Down score is more than 4, that means to say you need to act at this point of time. If it is less than 4, probably we may take a very pragmatic decision depending on where you are practicing. And of course don't forget again, irregular breathing, gasps, apneas or low saturation should be acted upon immediately. Next. So there are many pros where it is clinical assessment, no need of any gadget, easy to use, and research has been conducted using the Down score, which are all good. But again there could be a little bit of subjectivity here, which is possible. Next. So there was one good study done from St. John's Hospital in Bangalore where they found out between Silverman-Anderson score and Downer score which would be not better, probably more consistent to use, and they found that Down score was more consistent among all healthcare professionals including interns, nurses, consultants, everybody. So I think that seals the fact that if at all given a chance we better use Down score rather than Silverman-Anderson score. It does not mean to say that it is bad, but I think this is more advanced and more consistent. Yeah. So I was talking about what to act, right. So whenever you see this baby having respiratory distress, particularly restrictive type, always the initial point is starting CPAP. I think earlier there was a discussion about NIV and NIPPV and all those things, but as of today the first line of intervention should be CPAP, because that is one thing which is time tested, evidence based intervention which will reduce a lot of things. For example, in TTN it will reduce the duration of treatment, in RDS it reduces both risk of death as well as need of mechanical ventilation by 36%, which is huge. And if you take only need for mechanical ventilation, nearly half of the babies do not need mechanical ventilation if you do proper CPAP treatment. So that is the importance of CPAP. CPAP is the way to go. That is the first step to start whenever you see a baby who is having respiratory distress, particularly with the Downer score of 4 or more. Next line please. So why we are worried? Because when I was a postgraduate, the first line of treatment was giving oxygen, right. Any baby who came with distress, shove in an NG tube connected to that cylinder and turn whatever the amount of oxygen. So that was the time when I did my post graduation, and not much has changed since then, because even in many hospitals nowadays they just use oxygen by head box or prongs or whatever. But it should be avoided because we all know that oxygen is a drug. It can be toxic to newborn babies, particularly if they are preterm, and it is well said that the group of diseases that has been promoted or precipitated or even initiated by oxygen should be termed as oxygen radical disease in neonatology. And all these things, if you see any conference, any debates, we talk about all these things, right, in neonatology, and all of them have an origin with oxygen. So do not use oxygen very indiscriminately. It should be very much titrated, used only when needed, not otherwise, because it can harm. Okay, next please. Right, now we sort of understood how to assess the baby when the baby just arrives to us, but now we have put the baby on CPAP. Now we need a tool to assess the baby, whether baby is doing well or not doing well, or whether we need to act with some other extra sort of treatment. And when 2 or 3 people meet and speak to each other, there should be a little bit of uniformity about what we are talking. And so far, unfortunately, there was no tool available to assess the baby on CPAP. So all of us relied on the usual thing, like his FiO2 has gone up, his pressure has gone up, or something like that. But let us see why that should be avoided from now onwards. The PEEP management is very variable. Many people, many neonatologists feels that we can go up on the PEEP rather than FiO2 when there is chest retraction. There is nothing wrong with that idea, that is correct. So they just go up on the PEEP. Some people tend to go up on the FiO2 first and then try to turn on the PEEP. That is also not wrong, that is also one other way of doing it. Some people do it in an alternate way, go up on the pressure first, then the FiO2, then the pressure, then the FiO2. Even that is not wrong, that is another way of doing it. So there are a lot of different ways of doing it. So when we talk to each other, how are we going to make sure that we are sort of talking about the same thing? That is something which is lacking when we take individual parameters or individual interventions as assessment tool. That is where we thought that we will combine all these things and get onto a single currency where we can all speak about the same language. Next slide please. Okay. So this is a quiz for all the audience. These are all the different shapes of chest that we see. Can anyone say confidently that this is having a higher volume and this is having a lower volume? It is just not possible, because in the nature this is how you are going to see the chest wall shapes, right? They are all so much variable. If you remember the one video madam just showed, in fact she was on a CPAP, but actually the chest looked very bulged. So it is very much possible that they have very different shape of chest. So just looking at the shape of the chest and the retraction, it is very difficult to assess what is happening inside. Next. So this is the idea that we got. Now you have two different types of chest, and we need to find out the volume, right? That's what we are trying to find out. In the sense, we want to know how much is the disease, so how much is the lung which is usable. So how do you find out the volume? Now you can take a jar where you can measure the amount of water you can pour in and then pour it to each of them. Then it is easy. So this particular container has this volume, and this particular container has this much volume, because you have now measured volume that has been instilled into these jars. So this measurable, a standard measurable volume is what we have just devised, which is treatment, the extent, whatever the amount of treatment that we are giving and the response for the treatment, that can be used as a measuring jar. It's a little bit of I would say weird thinking, but probably it makes sense when you see the future slides. Any doubts, any questions here? I think I made myself clear for the next slide, right? So basically we are dealing with very abnormal shaped chest and very variable retractions where we cannot quantify the disease. Now we want to give some sort of treatment, and depending on the response to that treatment, we are going to say this is the amount of disease the baby is having, right? Next slide please. This I just explained. There is lot of variation in many practices, not just treating RDS, whether it is feeding, whether it is ventilation, all neonatal units have their own different practices. So much of variation is there, and if you keep this variation, particularly in certain aspects of research, it is very difficult to equate them. So we need to have a little bit of uniformity. Next. So this is where the concept of SOPHI came in. This is very simple: saturation, oxygen, pressure index, and this should be used for, okay fine, okay ma ಆಯ್ತು. ಇದು ಪಾಯಿಂಟರ್ ಅದಮ್ಮ, ಇದಾ ಪಾಯಿಂಟರ್ ಮುಂದ್ಗಡೆದ ಅಲ್ಲ ಪಾಯಿಂಟರ್ ಇಲ್ವ ಇದಕ್ಕೆ? ಓಕೆ ಫೈನ್ ಸರಿ. So this is the saturation oxygen pressure index, which is very simple to use. So this should be used on babies who have been already on CPAP, right? Earlier I talked about down score, which should be used on the babies who have just arrived. We have not even treated, might be a little bit of oxygen has been given. But once you decide that you have to put the baby on CPAP, then this will come into action, right? So what is the advantage? It brings about the uniformity in the way we express the severity of the disease. Okay. So this is the formula. There is nothing big here. As I told you, some people change PEEP, some people change FiO2. That's okay. You can do whatever you want. You can do it alternatively. And then what is the result? There is a change in saturation, right? So we will include those things, and when all these things are included, then you will get SOP index, okay? And all this FiO2 and SpO2 are in decimals, not in percentages. So if it is difficult for you to calculate, I don't know if any one of you have this Android phone. Now we have this Shishu app, the one in the middle, if you can see. Might be some people might be already downloaded this one. There is an NFI Shishu app where you can just go there. This is the app which we have developed, and SOPHI is included in this. Go to the calculator, cardiorespiratory, go to saturation oxygen pressure, just type in the numbers you have, it will give the value, right. So you can do it later. Okay, the first effort that we did to know whether this will work was a study of proof of concept. This I did when I was in Canada, because in that unit, I don't know it is fortunate or unfortunate, they were tweaking too much of PEEP rather than delta P. So whenever the babies were on ventilator, the first thing that they would change for improvement of saturation would be PEEP rather than delta P. So I made use of that opportunity, and I took these babies who were on ventilator. The first study was based on, derived from, data was derived from the babies who were on ventilator, and I ignored the PIP part of it, and we just took the PEEP. And then oxygenation index was the reference for me, and that time when we did this correlation study, we found the correlation was 94%. Again, I tell you that this cannot be reproduced unless the unit is working too much on PEEP rather than overall other ventilatory parameters. So this was a proof of concept which made me to go further. Then we did a clinical study with 57 newborn babies, and this was proper babies with RDS and on CPAP. And here, instead of oxygenation index, because we didn't have the baby on ventilator, we took AADO2, that is what is that? Alveolar arterial difference of oxygen, because this is a very comprehensive measure of the overall illness of the overall pulmonary illness. We took that as a standard, and we found out the correlation between SOPHI and AADO2 was 84.7%, which was very impressive. Then we calculated the score of SOPHI which was correlating with AADO2 of 70. It turned out to be 1.6 in this. So if the SOPHI is 1.6, then AADO2 is likely to be 70. Why did we choose 70? There was one clinical study done in PGI Chandigarh. That was very interesting, where they grouped babies who failed extubation and they grouped babies who were successful on extubation, and they found out what was the different characteristics of these babies. And one of the characteristics they found was the babies who failed oxygen had a mean AADO2 of 55 with a standard deviation of 17. So we just married both of them, mean plus 1 standard deviation, and rounded off to 70. So that was our opinion. Of course, it is not something standard. That was our opinion, that AADO2 of 70 probably is something bad, which makes most of the baby, around 67% of the babies, fail extubation. That means to say they need intubation. So 2/3 of the babies would need intubation if AADO2 was more than 70. That's why we have taken this number, and SOPHI of 1.6 correlated with AADO2 of 70. So next, after doing the clinical study, we did validate the same parameter, where we took two different groups. We conducted one training group, and then we conducted another training test group, and we could validate and even publish that study. Here we found a correlation of 82.7%, which was very good with AADO2, and what we found was a SOPHI of 1.52 was sort of matching with AADO2 of 70, and SOPHI of again 1.6 was matching with the AADO2 of 100, which is 55 plus 3 standard deviation of 17. So still that is okay to have that number. In our unit currently we are following 1.6. It is possible that some people might want to take it to 1.8 depending on the resource available and probably the patient they are dealing with, or might be some other units want to take it back to 1.5 and use it in a different way. It's up to them. I have given the list of all the different values of SOPHI which will correlate with various AADO2 in this article. People who are interested can go to. But overall what we can say is, now SOPHI is one of the validated tool to assess the baby who is on CPAP. So when the question arises, when should I change the gear? then probably you should look at SOPHI. If SOPHI is more than 1.6, then you have to change the gear. If it's your practice to intubate and give surfactant, do that. If your practice is to give NIPPV, do that, whatever it is, but that is the time to change the gear. So before I close, this is a proposal that I have done. It is not given in any textbook or any standard, it is not even published. What I feel is, and probably what we are practicing it, and most of the people will be practicing like that. We will see the baby at the beginning, assess the down score. If the down score is more than 4, then they are going to get their CPAP. Once the baby is on CPAP, monitor SOPHI every 15 minutes. For how long? For 1 hour. If the SOPHI improves to more than 1.6, then the monitoring frequency can be changed from 15 to 30 minutes. And after another 1 hour, after next 4 hours, if the SOPHI is still less than 1.6, then probably we are safe. We can reduce the frequency of SOPHI measurement to hourly or 2 hourly, whatever it is, and then take it from there onwards. If the baby at the end of 1 hour has a SOPHI which is more than 1.6, then please continue monitoring the SOPHI at 15 minutes interval for 1 more hour. At the end of 2 hours, if the baby's SOPHI is still more than 1.6, I think we have to change the gears. I don't think that we should wait more than that. Suppose if the baby's SOPHI has improved by 2 hours to 1.6 or less, then probably we can take this limb. So what are we going to do if the SOPHI is more than 1.6 after 2 hours? We are going to change the gears. Change the gears means depending on your unit practice and your experience and your preferences, either intubate, ventilate, MESA, just surfactant, insure, whatever, all those things can be done. So in a nutshell, I think assessment of respiratory support can be more and more objective from now onwards, where we have 2 scores, we can easily measure and we can act accordingly. And once we start doing this, then we all have a little bit of uniform idea of what we are dealing with. Thank you for patient listening. Any questions? Are the questions allowed now or at the end? I don't know, sorry. We can ask for questions? Yeah. If you have any questions, doubt, you can ask. Thank you.
I have a question, sir.
Yes, sir.
This SOPA is valid for preterm babies also or in-term babies also?
It's for respiratory distress, full stop. Yeah. Suppose if the child comes with pneumonia, say let us say congenital pneumonia, you can use this, no problem. Because in this study we have included both, basically preterm, but there are few term babies, might be few of them, but it can be used. Pretty much the same thing.
CPAP machine and technology is the next talk, but because so our next talk will be on CPAP interfaces, initiation, assessment, augmentation, breathing, and proper feedback. So this talk is by Dr. Monica Joshi. She's our national coordinator for the work.
Okay, I think we'll be little more practical to see how we will be dealing with these babies. So this is a 28 weeker, 1 kg female child born with preterm labor, and the mom received only 1 dose of steroid 6 hours prior to delivery. She was delivered by cesarean section, no asphyxia, distress was seen soon after birth. However, baby was in some primary center and so was shifted to the tertiary NICU after 4 hours of traveling to the on oxygen. So at admission the temperature was little hypothermic and the baby was quite distressed. The Silverman scoring was 7/10 and saturation was 93% on the nasal oxygen, and we don't know how much oxygen the baby was receiving. So this kind of a baby, if it is born with you, what kind of changes would you do for this baby? Would you do the same or would you do something different? Yeah. So you will not be giving oxygen just like that. We all know that the oxygen is going to cause a one free radical injury, and hyperoxia will be bad for the eyes, lungs and brain all. Plus also our baby is born preterm, and so there is a surfactant deficiency, so there would be lung collapse. So we will need to keep the alveoli open. The more you will keep the alveoli open from the beginning, the less would be the need of any kind of a ventilation, and we are all moving out of the non-invasive ventilation. So this is the, I think this not working, this there was a video not working, I think. So I mean anyway, so baby had retractions, and we have to put the Silverman score or down score, whatever you want to use. This should be right in place in your NICU, so that you know. I feel this is more easier, and because it's more related to the activity of the baby, and it doesn't depend on the what extra things you are giving, oxygen or something, because it's showing retractions and grunting and nasal flaring. So this was the chest X-ray, which you can see that there is a opacity. So in these kind of an X-ray and this kind of a baby, when it comes to your unit, we will have a more tendency to intubate this baby. However, we want to keep the endotracheal tube out because of the complications. We know that it is quite traumatic, painful. Baby goes into hemodynamic instability. There might be infections. Airway emergencies may come if the tube gets blocked or there is a pneumothorax. And resistance of work of breathing increases if you keep the tube too long, and air leaks are quite high. And this can happen if you don't really do your ventilation well. Also, you may traumatize the airway, and the airway lesions may occur. And hence we go for this kind of a baby that we can support non-invasively. Now non-invasive supports are many, like what she already said. It could be high flow cannula, it could be CPAP, it could be NIPPV. So because of the retractions and the grunting and the bad X-ray, definitely you are not going to put the baby on the high flow nasal cannula, and none of the research have shown to use as a primary modality in these kind of babies. So you can use either CPAP or NIPPV. And these are the modalities which you have as a non-invasive ventilation, like CPAP, CPAP, NIPPV and high flow nasal cannulas. They will be taken by, and then there is also a non-invasive high flow oscillatory ventilator as well, and a NIV-NAVA. So to know all these are the all modalities what we have. I will stick to the CPAP, and what our CPAP is going to do is that it assists in reducing the alveolar collapse, and especially at the end of the exhalation, and it increases the mean airway pressure, so it will improve the functional residual capacity. It would correct the ventilation, perfusion abnormalities, and so the intrapulmonary shunting would be reduced, and hence also the obstructive and the central apneas are reduced if you use CPAP. Pulmonary edema is decreased by the CPAP, so it works in a very nice way. So how do we set and how do we put the interface, and what knobs are we going to adjust? So first of all, we should keep our all things ready, and they should be all asepsis technique should be used to assemble them. So you may use a CPAP machine, or you may use a ventilator machine, whatever you use. The circuit should be fine, the everything should be on the aseptic cloth. You should use a sterile gloves and always a distilled clean water, whatever you are going to be using for your circuits. So on a it may be, as I told, baby can be connected to the, I don't know, when I sent I saw that my videos are not working. So let's do on this. So CPAP we can be on the bubble CPAP, which commonly we are using. So what we are setting is, we are going to look at the blender. So there will be an oxygen and the airway, both should be connected, so that you can choose the right FiO2 by turning the knobs of the blender. And to begin with, as we already say, we start with the 30% of FiO2, and we can go up and down looking at the saturations, and we want to keep our saturation 90 to 95. And then this is the humidifier. We need to have, we call it humidifier because we are humidifying as well as we are actually maintaining the temperature. So we are giving the warm air, is it, I need, so we are going to give the warm air to the baby and it should be humidified. And this is the CPAP generating pressure we will be seeing in our workstation as well. So how much you are going to dip this will give you the amount of pressure you are going to give. So this, you have a numbers here 4, 5, 6, 7, 8. So how much you are going to dip inside, that much pressure the baby would receive. If the baby is on the, once you fix, and also you have to be very, very careful on the interface what you are going to be putting. This is how the machine CPAP would look like, that you will be giving a knob which will be in, one knob will be for the flow, one knob will be for the pressure and one knob will be for your FiO2. And then there is a backup ventilation as well in when you are using the CPAP in a ventilator machine. So if the baby goes into the apnea, the ventilator itself may start giving some kind of a pressure. So this is how it would be looking like. So as we now understand what all knobs are there, what we said that we are going to set a FiO2, so we have to set a knob from the blender. We have to set a pressure, so which if we are using a bubble CPAP, we will choose the pressure and then according to that we will dip inside. If we want to give 5 CPAP, we will dip up to 5. But if we are using a ventilator, then we will choose the knob to 5. And then the flow. So usually we can change the flow, but usually what flow we are keeping is 5 to begin with. And we keep, earlier what we were doing, we were putting a rule of 5 to have easy understanding that and easy to remember, that you will use flow rate of 5, you will use pressure of 5 and you will start a FiO2 of 50. But nowadays, as we all know that oxygen radical injuries are much more problematic, so we have come down to 30. So don't go back to that 50 of FiO2. And then how do we adjust? As Dr. Srinivas, he is using his own innovation for looking at what he can do once you put the baby on the CPAP. But if we go more into practical things, then what do we look at? We look at retractions, we look at saturations, we look at the, we continue to look at SAS score, because SAS score doesn't change because you are giving some this thing. It tells that yes, if the baby improves because of the support, the Silverman score will get better. But if the baby is not getting better with whatever pressures or things you are used, the baby Silverman score will continue to be not okay. So these you can use them as an assessment for ongoing also. And also then you will have a blood gas which will give you your PO2s and your CO2s and your pH. And then you have your X-rays which will tell you what to do. So the FiO2 what you want to keep is between 90 to 95. And how do you know that your flow is correct or not? If you have put everything in a right, you will be seeing the bubbles in that water circuit. But if you don't see the bubbles, there may be some other issues, but one of the issue could be that the flow is less. So as I said that if you have a saturation which is less than 90 and you have lot of retractions going on, then what you need to do, you can increase your CPAP, PEEP. However, if your saturations are low but your recessions are not there at all, baby is looking quite okay, not retracting, not grunting, then you can increase your FiO2, okay. And similarly, how do you reduce? So supposing now baby is looking well, there is saturation is more, 90 to more than 95, and there are mild or no recession. So first thing what you will reduce is your FiO2. Whenever you start something, you want to reduce something, first you should see what is more harmful for our baby. So if you are going very high on your FiO2s, you will first bring down your FiO2, and for every 10% reduction in FiO2, you would reduce the CPAP by 1. So this baby was put on the CPAP and was given One extra thing what you will give a baby who's on CPAP and he was having this kind of X-ray, what would you give? Huh? Surfactant. So you would give a surfactant, and you can give surfactant in two ways. You can use either Ensure or you can use Lisa. So if you are using, we are using Lisa, and in that you don't need to remove the baby from the CPAP. Baby is on the CPAP and you are actually using a laryngoscope. It is not like it is totally non-invasive, but you are not actually removing the baby from CPAP. So baby's alveoli which are open up remain opened up, and you are not giving extra pressure, so you are not causing lung injury to this kind of a baby, and you use a small thin catheter. You can use a Lisa catheter, you can use an umbilical catheter, or you can use the OG tube, and you can give surfactant. So this baby was given surfactant, and after giving surfactant and putting the baby on the CPAP, baby improved. The Silverman score reduced to 4/10, FiO2 was less, flow was less, and over next hours it became further less. And so what plan would you do for this baby now? You can remove the baby from the CPAP and you can put on a high flow, okay, or you can continue for some time because it's a too small baby on a very low setting of a CPAP. However, what happens always, the Greg is not happy with the CPAP, and the baby may not show you this rosy picture, and the baby may look very bad. How would you look, what would you do if suddenly the baby on the CPAP starts looking bad? So the same dope what we are using for our ventilator, same dope can be used for our CPAP babies. So dope is what? You have used some prongs, okay, and so they may get displaced or they may get distorted, or the nose can get obstructed, that is O, and when the baby improved, you have given surfactants, so compliance improved, but you did not reduce your pressures. So you can cause pneumothorax, and there might be a problem with the equipment itself. So how will you go? So sometimes if you are doing a bubble CPAP and you may see that it's not bubbling. What can be the cause of not bubbling? One of the cause I said was that you have given less flow, but what could be the other causes for not bubbling? So either it could be a leak, there is a leak somewhere, or you have a partial or complete prong disconnect, or you may have a displaced prongs, or it may get actually obstructed totally, or you have chosen a wrong size of the prong. So choosing a right prong size is very important. If the prongs are too small for the baby, or they are too big, both of them would be a problem, or if the baby's mouth is open. So you will look at one by one and then you will rectify that. Sometimes you may have a baby who is too agitated on the CPAP. So these are all practical tips I would like to share, because these would be important help for us. So in that case, anyway we say that minimal handling should be there. You should keep your hands off. You should place your interface application properly. They should not be causing trauma to the baby. They should not cause pain to the baby. And you need to do a clustering of the care. That means you have to tell the nurse and even yourself that you would do things together at one point of time. So fix a time when you need to be changing the position of the baby, taking care of the interface, or you want to do suction, or you want to give antibiotics, or you want to do a blood gas or investigation. Cluster it, do it together. Don't keep going again and again to the baby and touching the baby. It will cause agitation to the baby, plus also it may cause infection to the baby, and also neurodevelopmental outcome would be bad for these babies. So clustering of care is very important. Feeding is very important. So baby might be agitated because he is feeling hungry, and as I said, hands off is always better. So be away and try to be monitoring from there. Sedative in these kind of babies are not recommended, because you want the babies to be actually breathing of their own, but you can use those kind of sucrose or some other pacifiers to make them happy. Then troubleshoot could be there could be alarm from the blender, as I said, there could be a blender, or there could be a malfunctioning of the blender, there could be leak in the circuit. And when we are actually putting the circuit on, what should you look for? There should be some condensation in the expiratory limb and there should be no condensation in the inspiratory limb. So sometimes what you will see the opposite, that there is a condensation in the inspiratory limb and there is no condensation in the expiratory limb. So you should know why is it happening. Just putting the baby on the CPAP machine is not going to work. We should know each and everything, why is it happening and how would we correct it. And there could be an inadvertent delivery of the high pressures. So you have to look at the blender, you have to look at the safety device. This sometimes, you know, there is a leak in that safety device, very important. And the condensation and water is important. So as I said, there should be no condensation in the inspiratory limb and there should be some condensation in the expiratory limb. Why would be there condensation in the inspiratory limb? So what can be wrong when this can happen the opposite thing? So what can be we will show you there that we are going to put a heating wire in the inspiratory limb. If the heating wire we have forgotten to put or it is not working, it is going to cause condensation in the inspiratory limb. Another thing is that if you are putting your, especially in the cold time when the room temperature is too cold, or if you have put an AC and the temperature of the room becomes too cold, this will cause a problem and condensation in the inspiratory limb. And the third thing, if your distal circuit is not under the warmer, that could also lead to the condensation in the inspiratory limb. So just look at those things and rectify them. And if you find no condensation in the expiratory limb, it is possible that your humidifier is not working, or also the opposite of the room temperature, that if your room temperature is too high, then also it will cause this issue. So these are very practical issues which we should be looking at. And for maintenance purpose, what we should look at, we should have disposable and not the reusable circuits, mostly because of the infection policies. Water should be in the humidifier, should be seen that it is there in the level, and water in the CPAP generator also should be at the level it is required, and blender should be functioning and pressure measurement should be done. So basic requirement is pressure generator, grading of the oxygen by the blender, humidification. The pressure can be generated by either the ventilator or the bubble CPAP, and the oxygen how do you give is by blending oxygen and compressed air, and you should use a servo controlled humidifier. Now when do you say failure? As he said that you can have the score and say it's failure, but if you look at the baby clinically, and she had in her presentation had already talked about the failure of any NIV. So if the baby continues to do retractatory grunting, they are apneas, or if you have done a blood gas which is showing PO2 which is lower and PCO2 which is going higher, and you are requiring a FiO2 of more than 60%, that means it's failure. And also sometimes the baby is not tolerating the CPAP, could be a failure. So the reason could be that the CPAP system is not working, or baby is worsening respiratory wise, cardiovascular wise, or a neurological wise. So how do you identify newborns at risk of the CPAP failure? So first of all, you should have a criteria in your unit, when will you define the failure, and then usually if it is a very small baby, if it is a very less weight baby and is born with a disease severity, the chances of failure is quite high. If the obstetricians have not given antenatal steroids, then also the chances of failure are high. And also the unit experience of using the CPAP is very important, because don't think that it is just a very easy thing and ventilator is the more difficult thing. I would say as far as nursing experience is concerned, CPAP is a very time consuming kind of modality, and so you should have, if you don't have a good experience, then you might fail. And then supportive care, nursing care is very important in this. Also what kind of equipment you are using, what kind of interface you are using, that is important. And when did you start CPAP? Like if you start late, then it is going to have a less effect. And whether you have given the concomitant surfactant or not would also define. And then again it may happen that baby is septic, baby goes in shock, or baby develops PDA, then it may show a failure. So to improve the CPAP success, we should ask our obstetrician to give antenatal steroids. We should start our CPAP in our delivery room, and we should have infant characteristics well noted, that if it is a mild to moderate RDS, we should put the baby on CPAP. If the baby is totally asphyxiated, don't try to be like, I want to use only non-invasive modality. Those babies might need to be put on invasive ventilation. And give an early surfactant. And setting, when you say that some people are using more, but our unit we are not using more than 8 CPAP, and if we are already on 8 and FiO2 of 7, then we say that after that we we are saying it's failure. And CPAP interface, like use a short binasal prong instead of earlier I remember when we were in, I was doing my MD, we were putting a endotracheal tube in one of the nose and giving CPAP in PGI way back in 1996. But that is not to be used anymore, and we need to be actually using a binasal prongs and not a nasopharyngeal prong. And also we can use now because of, I will come to that, injuries, we are also using the mask, and we are actually rotating between the mask and the prongs. So the nursing care is very important, that we need to ensure that we are applying the CPAP interface properly, and we should ensure that we are actually delivering the pressure adequately, so that there should be no leak in the gas flow in the circuit, and water level should be seen that it is proper and dipping is proper. The nurses should make sure that there is a this neck position is very important, so they should be in a semi-extended position. They should not be too much flexed or too much extended position, and they should be clearing the nasal secretions at a regular interval, and humidification they should be looking at. Then the another nursing care which is important is that they should have a charts to monitor the respiratory. I will show you one of the chart which was made by one of my friend, Dr. Srinivas Murki, has worked a lot on the CPAP, and they should be regularly inspecting the nasal trauma and looking at temperature, perfusion, sugar, fluids. Gastric distension is very important, one of the major cause of the failure of the CPAP, because if they have started the baby on feed and they have not opened the OG tube and it is accumulating lot of gas and causing CPAP belly, that should be taken care of by the nurses, and we have to keep telling them to keep doing it, and asepsis is very important. So this we talked out that we should look at humidification, rule of 5 except for the FiO2, and we should look at the CPAP pressure by looking at the recessions and X-ray, FiO2 by looking at the saturations, flow by looking at the bubbling, and proportion of FiO2 and CPAP as at for 10% and 1, that is how you will go up and down. And this is the monitoring sheet for the CPAP which you should keep. So it looks like very big, but this is how you should be. So the monitoring should be of the baby, and also it should be of the Silverman scoring, and also it should be of the here, because this we forget about that, we have caused trauma to the baby thing. So we should have that how much space is between the cannula and the columella. There should be 2 millimeter of space, otherwise you will cause pressure and cause trauma. And nasal bleach is happening or not, these things is very important, and this monitoring chart if you do not have in place in your nursery and you have put the baby on the CPAP, it is not good. So how do you troubleshoot? If you had saturations are low, retractions are there, and air entry is poor, bubbling is there, so that means it is a problem with the lung disease. However, if you have low saturations, retractions are less, air entry is good and bubbling is also good, that means either the baby has got PPHN or some congenital heart disease. Or if there is a saturation is normal but retractions are too much, air entry is good, bubbling is also good, so it could be due to metabolic causes. And if there is a low saturations with retractions and poor air entry and bubbling is there, it could be obstruction. If there is no bubbling, then it could be due to leak. So these are very simple practical tips to see where the things are going wrong, so that you can actually target yourself to that. So if you should look at if baby is fighting in the interface. Do I have time or it's over? Huh? Over? Okay. So because these are all practical things, we can take later, yeah. So I'll take next part later, which is on the what all monitoring should be done when the baby is on CPAP in detail. Thank you. Any question you want to ask? So if that's what we said, that flow you will start with 5, but if you see that everything else is going fine and the bubbling is not happening, then you will increase the flow.
Good morning, everyone. Today I have been given the topic of supportive care of baby on CPAP and also its complication. I know that there will be a lot of overlapping because all of us are talking on CPAP, and most of my slides have been covered by Dr. Monica, and some of the slides may be covered by Dr. Jagdish in the next presentation. But I'll stick on to the important points. Mainly, I come from KMCH, Koya Medical Center in Coimbatore, where we take care babies from 24 weeks of gestation, and I got experience in Australia. I was there for almost 9 years, and I've introduced almost all the aspects we were doing in Australia. And our neonatal outcome, less than 1000 grams, is around 90%, and 24-25 weekers approximately above 80%. This is our outcome, and this is what I have started in our NICU in the supportive care. So this NIV has really revolutionized the care of newborns, especially premature babies. Previously, when most of the babies were dealt with only invasive ventilation, we had a lot of complication, increased chronic lung disease, increased complication, and there was a lot of deaths also because of that. So here, non-invasive CPAP has really decreased the requirement of intubation, decreased the requirement of surfactant, improves the surfactant function, reduces the lung inflammation and lung injury, and also decrease the incidence of chronic lung disease, IVH and ROP, and overall it improves the neonatal outcome. But the same CPAP, if you don't use in the proper way and if you don't give a proper supportive care, you may have all these complications occurring more. So every NICU managing neonates or premature babies should have a CPAP. Yeah.
Okay, please. You people are everybody in the group. Everybody in the group. Yes. Who is not there in the group? Who is the responsible person for this thing? Abhishek. You are the admin, right? Prajwal. Who is Prajwal? Okay. Come add them in the group. Number 1 first. Please, government authorities might come now. Wear the mask. Everybody just like this. They might take. Okay, one photo. Wear the mask. Wear it. Okay. Then please send your 2 vaccinations right now in the group. Ajay, you know you have taken the 2 vaccinations. Yes, sir. Who is not taken, sir? Everybody. Please, it is there in the ROTC. If you are not taken, please walk out when they are coming. Please don't stay. If you are not taken, don't stay. Okay. Problem for everybody because of one person. Okay, number 1. Okay, put it in the group, sir. Sir, I will take 2 minutes. Sir.
Yeah, that's fine. Take your time.
Just mandatory.
Yeah, that's
because
fine.
if you put today, tomorrow there won't be any problem. And whenever government people come, you just wear the mask. No need to go now. Mask, when they come out, no need. You open this.
Okay, we'll be back to the presentation again. So as I mentioned, every NICU has to have a CPAP. If a NICU doesn't have a CPAP, that's not ideal for a level 3 care. It should be much lower. and a good supportive care is very important. For this, you have to educate your nurses. Without educating nurses, definitely you can't get a good outcome. Appropriate action at the right time can minimize the complications and improve the neurodevelopmental outcome and overall outcome. Now, what can be prevented using CPAP? So, we talk about all these traumas routinely, volutrauma and barotrauma being the major ones. Then we talk on oxytrauma, which is silent killer. We think every baby who is saturating around 100% is doing well. But if you are giving too much of oxygen at that time, you will be causing more harm to this baby rather than getting them better. And also never forget about the atelectotrauma. Never allow the lungs to collapse. Once the lung collapses, once you try to open again, it will cause lot of stress and induce inflammation. So that's one of the reasons why you should start CPAP right at the delivery room. So if you start CPAP in the delivery room, you are not allowing these airways to collapse and you can minimize the inflammation. Biotrauma, of course, preventing infection and inflammation is very, very important. Rheotrauma is related to flow, not very important. A good supportive care is very important to prevent all these complications. Again, without supportive care, these complications can increase. I think the CPAP connection has been told by Dr. Monica, so I'm not going into the details of connection. So follow the procedure perfectly. So that is very important, step by step following the procedure. Never forget to put on the humidifier. It has got a major role in a good outcome of these babies. Proper selection of the prongs is very important. Fixing the tube properly, that's also very, very important. I think I got a lot of slides. Mainly it will be a picture presentation. Check for raining in the tubes. So if you see it raining anywhere, both inspiratory and expiratory limb, you may be causing harm. So inspiratory limb, you are going to drown the baby. If you see it in the expiratory limb, that may give an artificial higher CPAP, which could be harmful. And check nasal septum very frequently. Please don't forget about the nasal septum, because injuring the nasal septum is like a permanent damage to this baby. Because especially once you damage the septum, because there is no significant blood flow and the septum can't grow back to normal. So you have to prevent this. Nursing care specific to CPAP. Perfect connections are again important. Checking the proper functioning of the circuit regularly is important. Proper selection of interfaces. Humidification, very, very important. Once CPAP is connected, you have to keep it patent, you have to keep it working. Should be secured correctly and also should be examined very frequently. Frequent check of the proper function is very important. Now coming to the supportive care. First of all, very important is your hand hygiene. Preventing infection is a major important aspect, because all your hard work can go in vain with one episode of infection. So preventive infection is the major important thing. And I can say till recently we had an infection rate of less than 2% in our NICU, but just few months back we had a outburst. It went up to almost, we had a 5 or 6 cases. Then we took several measures and now it's back to less than 2%. So blended oxygen and air is very crucial. I think Madam has told about the details of this. Common errors during this supportive care, what all you can observe. Humidifier, please check regularly. Level of water, if it's not maintained, it may cause problem. Water entering the nasal prongs, this can drown the baby. No gap maintained between the septum and the nasal prongs. So that's what can cause the damage. And also you have to secure the CPAP circuit, because all the tubings are very heavy for this baby. So if you don't secure them properly, you can, I don't think I got a pointer here. If you see here, the one which I marked in the yellow, this was devised by one of our nurses. It was a good innovation, because I did try lot of ways to secure the tubings without pulling the tube down, but we couldn't. Even the biomedical people tried a lot. Then subsequently one early morning I found this, which was securing the CPAP circuit, and this did a real wonder for us. And after this we hardly get any inflammation in the nasal septum. It's just a glove filled with water, and it's placed on the tubing, and it nicely mounts with the tubing, and the tube doesn't go down at all. And CPAP generator, always it should be below the baby, because all the rain out, if at all happens, it will go back to the CPAP circuit if it is below the baby. Appropriate prongs, bonnet or CPAP is very, very essential. Now these are all, I am not going to the detail, these are the items which are needed for the CPAP connection. And this is the prong sizing guide. Now we have got a new one which has got sizing guide for even for the masks. Then this CPAP has to be connected in the midline perfectly. Otherwise again you may cause a lot of problems. Nasal prong selection should be perfect, and chin strap if you are not able to control the leakage. Routine chin strap is not needed. Only in some babies where you can't control the leakage you can use the chin strap. This is roughly I put a CPAP circuit just to know how it is. The details have been told already. And if you see here, just to avoid the nasal septal injury, here there is a hydrocolloid material used. And in our NICU we use the normal duoderm. I've got a picture next one which is cheap and works equally well. And you can see the CPAP generator and the humidifier well below the baby. So here this is what we use in our NICU. This is the routine duoderm. So this is the way we cut the duoderm, make a hole with the punch holder, and then just open it up and fix to the baby. And on top of it we just put the prongs, and hardly we get any injury. But still you have to look at these prongs regularly just to make sure you don't harm the nasal septum. So this is how it looks afterwards, and if you are using a mask, I have got the two pictures on that side. CPAP in delivery room. So why we have to use CPAP in delivery room? Even if you are using in delivery room, it has to be blended. Never use 100% oxygen. You will be harming the baby initially itself. It has to be blended. If you don't have a blender, this is a simple way you can have a Y circuit connected. I have written a calculation how you can calculate what is the percentage of oxygen the baby is getting here. So roughly 3 liter of oxygen and 3 liter of air. If you look at here, this is how calculation can be done. 3 into 100% is 300. 3 into 20%, air contains around 21, I have just rounded off. So that becomes 60%. Similarly, you put 2 liter of oxygen and 4 liter of air, same calculation, 2 into 100 and 4 into 20, that roughly comes to around 46.7%. So this is a rough estimation of what oxygen you are giving the baby. Never give 100% oxygen. Still good it will be if you can use a humidifier even in the delivery room. We have not started. Only for this preparation, when I looked at, I saw this picture. I have already told my biomedical people, work on this and we will try to introduce. So why you should not use pure oxygen in the delivery room? This study was an excellent study published in 1996 by Neil Feiner. I put up these pictures in all my presentation on NIV or high flow presentation. Here these were 2 sets of babies, less than 1500 and more than 1500 grams. About 18 babies on this category and 13 babies on the other side. And here what he did was he gave a nasal prong oxygen which was humidified, and in increments of 25 ml, not liter, in increments of 25 ml, he took samples from the pharynx and checked what oxygen concentration was going to the baby. So even when the baby was getting around 200 ml, that is 0.2 liters, the oxygen concentration in baby less than 1500 grams was almost 50%. And if you give about 300 ml, it can reach 100%. So in babies more than 1500 grams, if you give about 200 ml, still you can reach around 50%. So using 100% could be a problem. Again, he himself published another one study. Here you can see, after all this calculation, he said that in a 1 kilo baby getting about 300 ml per minute, baby breathing at 40 per minute will get 100% oxygen. And even in a term baby who weighs 3 kilo, if you are giving 1 liter per oxygen, who is breathing around 40, will get 100% oxygen. This is based on this study. So that's one of the reasons why we should never use direct oxygen in these babies. It has to be blended always. So why you should not be in a hurry to bring up the oxygen to 100% while delivering in the delivery room. So here every fetus, when the baby is in utero, is saturating only around 60 to 90%, and PaO2 ranges anywhere between 20 to 60, averaging around 50-60. Why we have to be in a hurry when the baby is delivered to take it to 98 or 100%? So every organ, especially a premature baby around 28 weeks, 26 weeks, the organs are programmed to develop in a hypoxic state. And if the babies are delivered early, if you subject these babies to high oxygen concentration, that can cause significant harm to every organ of these premature babies. Now, again problems with CPAP. Requires skilled nursing care. Maintaining the circuit is a real challenge with these babies. Uncomfortable hats and chin straps. So if it is uncomfortable, you have to look at the baby. If they are not comfortable, you have to loosen very frequently and make sure you keep them comfortable. Make sure it's a tight fit without dilating the nostril. If you dilate the nostril, that itself will cause the problem with columella, and the figure of the nose itself will change. Condensation in the tubes has to be checked frequently. Again, why you should not give without humidification? The oxygen which comes directly from the central connection, temperature can be 15 degrees centigrade or much lower. In Western countries, it's almost minus 20. So the humidity is only 2%. The lung requires 100% relative humidity. Absolute humidity is around 0.3 milligrams per liter. The lung requires 44 milligrams per liter. So if you give directly from the central connection, you are going to give a dry, low temperature oxygen, which can cause damage right in the beginning. So unless you take care right from the delivery room, by the time the baby comes to the NICU, you have caused the initial complication to these babies. So you have to prevent this. And I know there is a talk on humidity, so I won't go into the detail, but this is a part of supportive care. That's one of the reasons. If you don't give proper humidity, this can cause lot of heat and water loss, improper gas exchange, decreases energy for the growth, increase the risk of infection. You can see on the other side, that is the one with proper humidity. All the cilia will be functioning adequately, carrying all the bacteria and mucus outside. And this is the one with poor humidity, where entire cilia is dead, and the function of the cilia has also gone. So both the strokes, recovery stroke and the stroke, both are affected in this. So what are the complications? Again, it can increase the infection rate. Just one thing about this is the water vapor is very, very small in size. Okay, a vapor cannot carry either bacteria or virus. A droplet can carry both. But a vapor, because the size of the vapor is only 0.0001 microns, whereas bacteria and virus are much larger. So if at all the infection has to go into the baby, it has to go through the surface of the circuit. So if you keep the circuits clean, infection can be totally prevented, because water vapor will never carry infection. This is what happens if there is decreased immunity. Initially the cilial function will be perfect when you have got 100% relative humidity. As the humidity starts coming down, initially the mucus gets thick, and then the clearance stops, and then the cilia stops, and then there is a cilial death. So again, so this basic concept all of you should understand. Unfortunately, I don't have a pointer. That's a big problem here. Okay, here if you look at the end of this, the temperature of the tubing will be around 37 degrees. The water vapor which comes is 37. By the time it reaches here, it will be 40 degrees. It is further heated up from 37 to 40. Why you have to heat up to 40 where the baby requires only 37? That is the temperature has been hiked for the interface. When the baby air is moving through the interface, there is no heating. So based on the atmospheric temperature from 40, before it enters the baby, it will drop down back to 37. And that's what is going to go. Why it can't be heated there? If you heat there to 40 degree, that vapor will carry more water vapor, because it has been heated. The more the air is heated, higher the content of water vapor. So because it's heated only up to 37, it contains sufficient water vapor for 37 degrees centigrade, and gets heated up to 40 without any additional water vapor, and then cools back to 37. There is enough water vapor for 37 degrees. So there won't be any condensation. And most often this condensation you can see here, I don't know whether it is clear, that should not happen. So the whole thing has been explained in those pictures. This is the latest. I think there is one recent advances, probably that may be covered. I am not going to the detail. Fisher and Paykel has come out with a new one, humidifier, which is an excellent one, but it's a bit expensive compared to the other one. Here you can have minimal condensation. We did check for 2 weeks. It works perfectly well without any problems. Lot of connections are less. This can, you don't have to disconnect the circuit frequently to evacuate all the water. Therefore, CPAP is maintained continuously, lung recruitment is maintained continuously, infection is minimized. So here, care of the airway, again all suction catheters should be available for routine suctioning. Suction pressure should never be above 100 millimeter of mercury. Clear the infant's oropharynx first. If it is binasal prong, suction mouth and nose, generally done every 6 hours, but need not do every 6 hours. Unless there is secretions, you don't have to go for. Initially, if the baby has got lot of secretions, you may require more frequently, and then subsequently only as needed. If secretions are very thick, use normal saline to loosen it, then you can take it out. So this is inserting the orogastric tube. Whenever you are doing a CPAP, you have to have a orogastric tube so that you are introducing lot of air into the stomach also when you are giving CPAP. That has to be drained freely. So you have to have a orogastric tube if you are doing CPAP connection. And one of the complications here, that is the CPAP belly. If you don't have a proper orogastric tube, even otherwise sometimes you can have problems in some babies, even if you have a orogastric tube, but it will minimize the complications. Check for the equipment function regularly, that is especially the bubbling. Only if it is bubbling, the baby will be getting enough CPAP. Otherwise, it may lose the CPAP, and make sure the humidifier is always functioning. So this is check prongs every 15 minutes in the first 2 hours, especially in extreme premature babies, because that is the time when skin is immature, and that is the time when skin can get damaged very easily. By 1 to 2 weeks, the skin matures adequately and chances of damage minimizes. So check prongs every 15 minutes in the first 2 hours. If you don't have any problem, then every 30 minutes in the first few days, and then once the baby is 1 or 2 weeks old, you can minimize your checking, but better have an eye on it. The ideal gap should be around 2 to 3 millimeter, but at least 1 millimeter is important. These are all different circuits which I have put here. So now common complications on CPAP. If you look at, this is the first one where the septum is totally damaged. If it is a female baby, they have to spend additional 1 crore or 2 crore for dowry. So we have to prevent this septal damage. And these are all the other damages because the interface circuit. And again, this is the synechia of the columella caused because of the prolonged use of CPAP. So this has to be prevented by selecting the ideal prongs. And this is because the tight CPAP interface. And these are all the different complications. It could be even due to the adhesives. Monitoring during CPAP, very, very important. Physical assessment and monitoring should be done regularly. And for all this, if you educate your nurses, they are really good. We depend on nurses mostly because we are 3 neonatologists, we spend a lot of time on teaching them. So weekly we have got 3 to 6 classes, and we have got an educator separately. They also take classes regularly to them, and that's how we are preventing a lot of these complications. So initially at least half hourly it has to be checked, thereafter hourly observation, and then as needed. So this is a general target zone of oxygen which we target, 90 to 95, some say 91 to 95, both are okay. So that's very, very important. If you have a support of transcutaneous machines, that will be very useful, but we don't have in our NIC, we are planning to get one. So this will be very useful if you have these Massimo pulse oximeters, especially Radical 97 with the trends in it. It will be very useful to decide whether the baby can be weaned off CPAP. We regularly check on this and then decide whether the baby can decrease CPAP. If you look at here on this side, saturation between 96 to 100 is only 32%. Saturation between 91 to 95 is 39%. This is 24-hour saturation. We take a trend on that histogram. And 86, this is not a good one. This baby is not ready to come off CPAP. On the other side, if you look there, saturation between 96 to 100 is almost 89%. 91 to 95 is 10%. That is almost 99% of the time the saturation has been above 90. Okay? So this candidate is ideal candidate to trial of CPAP. So with this, we have success rate of taking off CPAP very good. Hardly any baby we take off CPAP, come back. Only thing, if they come back to CPAP, it's because of secondary complications of sepsis or feed intolerance. Otherwise, they do really well. So all the vitals has to be checked as a supportive care for CPAP. That's why I put up a chart. Temperature, very, very important. Heart rate, you have to know about the basal heart rate. Every baby will have its own basal heart rate. A premature baby around 24, 25 weeks, after 1 or 2 weeks, their basal heart rate is raised because we give caffeine, the heart is relatively small. So if you look at the chart, you will know what the basal heart rate of that baby. Some premature babies can have a basal heart rate of 160, 180 or even 190. So a raise of basal heart rate more than 20 is significant, you should start examining. More than 30 is definitely significant, you should start interfering with the baby. Something could be wrong, but always be aware, some external factor like a feeding or a crying baby or handling can increase your basal heart rate. Basal heart rate is checked only when the baby is calm and sleeping. Again, respiratory rate, BP. BP is one thing which is neglected in many places. This is very, very important. If the BP is dropping down, that may be the first sign where you have to take care of these babies more vigorously. Otherwise, by the time you recognize, you could have damaged most of your organs and then it becomes more and more difficulty. So one of the good point is whenever the urine output relatively comes down, that may be an indication that BP is dropping. But if you check BP regularly, you will not miss that. And blood glucose level, initially you can check hourly, but once it's stable, you can go 6 hourly, 12 hourly or daily. So if everything is stable, then we go only 24 hourly for babies in NICU. So blood pressure, I told you, any hyperbolic shock could be because of low blood volume, cardiogenic shock maybe because of the heart failure, septic shock is mostly because of distributive, then these are treated by bolus, inotropes or soda bicarb. Urine output may be the earliest indicator where the volume has come down. And again, never forget about the nutritional support. I am not going into the detail because we don't have much time. Nutrition is very, very important. In all babies less than 1.2 kilo, ideally you have to start TPN. And any baby more than 1.2 kilo whom you think you can't reach full feeds by day 7 or day 10, you have to start TPN. At least give protein initially. Why neonates are more susceptible to acute kidney injury? I think this was told by madam, and this is mainly because of the developmental immaturity and the hemodynamic changes can affect the kidney first. Kidney, intestine and the skin are the affected ones because all the vital organs are spared. So urine output significantly comes down without change in any heart rate or functioning. So that will be very important. Just tell me if I am running late. So methods to maintain optimal temperature. A figure conduction can be prevented, conductive heat loss can be minimized using thermopad, warm clothing and warm bed, and convection can be minimized by using a plastic wrap. Here I put convection is because of the air movement. Incubator and limiting the movement of air over the baby. Evaporation can be prevented by wiping off the wet areas over the baby and increasing the humidity in the incubator, and radiation is by using a radiant warmer, keeping the surrounding warm, especially the room temperature, and using a double walled incubator. Watch for emergency problems. This is very, very crucial complications while using CPAP. So obstructed airway, madam has told about that. Most important thing is pneumothorax. If a baby who is doing very well suddenly goes down, always check for pneumothorax. Simplest way is use a torch and keep it on the chest. If you see it glowing, the entire chest will be glowing, then definitely it's a pneumothorax. You don't have to wait for the X-ray because baby can get sick. You can, at least you can use a needle aspiration till the X-ray comes, and then you can go for an ICD insertion. And pulmonary hemorrhage is another significant complication which you have to prevent using a CPAP. If you see a pulmonary hemorrhage, you don't have to be in a hurry to intubate these babies. Hemorrhage can be just controlled just by using CPAP. You have to increase the CPAP 6, 7, 8, 9, 10, 11 or 12, any amount, because hemorrhage can kill a baby. One of the complications using high CPAP is pneumothorax, but you can treat pneumothorax. But if you allow the hemorrhage to happen, soon you will lose the baby. So control the hemorrhage by increasing the CPAP. So only if you can't control the bleeding with increasing CPAP, even up to 10 or 12, then you can think of intubation. But you have to be very careful because a baby whose hemorrhage is not controlled with CPAP of 10 or 12 can profusely bleed once you take out the CPAP. Try to intubate only with the CPAP in. Other supportive cares, you have to look at the fluid balance, observe for abdominal distension, look at the IV site regularly, document it hourly. IV site redness, swelling, blanching and leaking, all this has to be looked. All these pictures tell us about it. And this is another important slide which I went through. Unfortunately, I couldn't get the reference for this. I was searching for 2 days, I couldn't get it. So this was in one of my presentation. So if you use CPAP, it has to be optimal CPAP. If you use less CPAP, oxygen is not going to be better, your CO2 retention is going to be more. Once you use optimal CPAP, maybe 5, 6 or 7, that is the best time when you get best oxygenation and best CO2 washout. So if you go anything beyond that, you may be causing more harm. Again, PO2 starts coming down and your CO2 starts retaining. So you have to check the optimal CPAP for every baby you treat, and most of them are comfortable of CPAP with 6 centimeter. Down is care, I am not going to this. This has been told almost 2-3 times. CPAP related underinflation or overinflation. If you look at if you think baby is not doing well, you can just take an X-ray and see. If the lungs are not inflated up to 8 ribs, then probably it is underinflated. You have got a room for increasing your CPAP pressure. And sometimes, even if you are saying 6 or 7 centimeter, the baby suddenly may start going down more gradually. You see that oxygen requirement is going up. Again, the X-ray will give a useful information. That is, if the lungs are overexpanded, it is going to compress your lungs. If the if the heart is compressed, the volume going to the heart decreases. Therefore, the output of the cardiac output comes down significantly. So that will cause again a decrease in oxygenation. And if you think any other thing is here, you have to decrease back your CPAP. Then baby will start improving. At that time, you have to spend more time on the bedside to see what happens while decreasing the CPAP. If the oxygen starts getting better, probably you are overinflating. If the oxygen gets worse, you have to go for the next step. And again, this is the CPAP belly. And overinflation causes a lot of complications. It increases the cerebral venous pressure, compression of the heart, decreases cardiac output, increased oxygen requirement, decreases GI blood flow, causing feed intolerance. CPAP belly decreases renal blood flow, decreases the urine output, increases the ADH, and also increase intracranial pressure. So overinflation could be dangerous for these small babies. Skin care, again, very, very important, especially in the first 1 to 2 weeks. As I said, that is the most delicate time for the skin in an extreme premature baby. You have to take care. Again, medical adhesive related skin injury has to be prevented. So you have to use all the very important, even while using adhesive also you have to select the proper ones. So this is last few slides. Developmental care during CPAP also should be taken care. So keep the baby in a swaddling position. Swaddling position is the position how the baby was in utero. So that position will be more comfortable for the baby, and that also helps in good development. The other thing is nesting. Nesting helps in lot of it keeps the baby comfortable, and also it covers most of the surface of the baby, helping the sensory system to develop much better. Lights and noise should be minimized, but should be exposed both to dim light and white light and also the dark light. So you have to have alternate, but not too bright light. Light music is really beneficial for the development of these babies. Every NIC should have a quiet time daily, especially in between around afternoon, around 3 to 5 o'clock, and give them some quiet time where absolutely there should not be any noise in the NICU. Kangaroo care will be really helpful once the baby is ready. So baby on CPAP, probably it's difficult. Baby on high flow can go on to kangaroo care. And different positions of the baby also is very useful. Last slide, useful nursing tips for babies receiving oxygen and CPAP support. Do not titrate FiO2 frequently. Though we have 90 to 95, though the target saturation is 90 to 95, sometimes some babies will just go to 97, next second they will come back to 93. Thinking that it has gone to 97, don't try to wean. So persistently high oxygen more than 95, say more than 10, 15 seconds or 20 seconds, then you can start weaning. Just up and down, you don't have to. Frequent titering may be harmful also. Make small changes at a time, decrease FiO2 if persistently above 95, and increase the FiO2 if it is persistently below 90. Desaturation with bradycardia is more significant. Extreme ups and downs and in the SpO2 are very risky. Allow the baby to fluctuate within the desired saturation. After suctioning, recruitment may be needed. If you are taking off the CPAP for suctioning, that's the time when the lung can collapse a bit. And then once you connect back, the oxygen will start going up. So if you think the recruitment has gone, we'll have to increase your CPAP further up. Once within few seconds or a minute, the recruitment will happen, and then you come back down to the same set of CPAP. Always stay with the infant until the saturations are stabilized. So what we are doing now may not be correct in the future. So learning is a never-ending process. Thank you. Any questions, please?
Yes. Oh, fine.
This is Dr. Jagdish Chaturvedi. I am an ear, nose, throat surgeon. You must be wondering what is an ENT doctor doing at a neonatology conference talking about new advances. I particularly deal with CPAP in the older individuals who have obstructive sleep apnea. I don't deal with babies and newborns. But I wear another hat which is into innovations. I've been inventing devices for the last 12 years, and newer technologies and new developments is what I do, and I facilitate other doctors and other healthcare organizations to make newer technologies that can help our patients and our hospital settings better. So I've been asked here to give you a very quick overview. It's not a long presentation at all. Just a quick overview that in CPAP, where are the advances taking place? What are doctors and companies focusing at? And where are lacunae and gaps where more innovation is required? And that's the purpose of my talk today. So I don't have to emphasize this. We all know that there are a lot of babies who have mortalities because of respiratory distress. This is rising in number, but there have been very specific changes that have occurred in our environment post the COVID pandemic, and the pandemic is not yet over, and a lot of requirements are changing because babies are often required to be transported more often. It's not possible to crowd the hospitals anymore. It's not possible to keep the same capacity of patients that you had once before. Expectations from patients and relatives are constantly changing. I remember once I was talking to a neonatologist in a rural part of India, and he clearly said, I don't use CPAP at all. I directly put the babies onto a ventilator because I get only one chance to put the baby into a care setting. If I say I'm putting on a CPAP, bubble CPAP, and then I have to upgrade to a ventilator, patients and parents refuse. They go somewhere else. So I put the baby on a ventilator and put them on a supportive mode, and then so that I don't have to scale up as a separate activity. Even though we know CPAPs can be made by ourselves using just a small water column and a bubble jar, but a lot of these expectations are changing, and transportation, portability, compatibility with a lot of other systems is now the requirement. So I'm going to show you a really bad slide. This is not a good slide, but this is an actual comparative analysis done by researchers that was published in Innovations BMJ on low-income countries. What are the categories of CPAP and where are the innovations happening? You can find this article online for free on Innovations BMJ. This is the latest advances in CPAP. So basically there are 4 categories. I know it's not readable, but there is a low-cost unbundled CPAPs. These are CPAPs that we can make on our own. These are very simple, mechanical. They don't have any technical features. They're usually given in very early stages to give primary support to the babies. And then there are certain improvisations that people do on that by having some sort of an oxygen support and some sort of external humidifiers. But I wanted to focus on the medium cost bundled CPAP. This is where 90% of technology advances are happening, and I think there are at least 4 or 5 companies that are showcasing their products here today that fall under a medium-sized bundled CPAP. Bundled CPAP meaning that they have their own airflow generators, They have their own internal humidification system. They have their own monitoring systems, alarm systems. They have their own ways to measure FiO2, and they are smarter technologies. And they are more portable, they have battery backups, they can be transported from one place to the other, and most importantly, they fall under medium cost. The reason why the technology advances are happening here and not in this far end, which is high cost unbundled CPAP, which are our traditional CPAPs that are there from international companies that we import. These are still there, but they are not newer innovations occurring in these areas because the problems are growing more in the lower income and middle income areas, especially even in India. There's urbanization happening in rural parts, semi-urbanization happening, and many new private nursing homes are being opened by doctors, doctor families, doctors grouping up together, making 8-bedded, 10-bedded nursing homes. They have a very specific requirement that they don't have the best skills available, they don't have the best nursing care available, they don't have the best infrastructure available, but also they don't have the budget to import large expensive technologies that have expensive tubings and expensive armamentarium that comes with it. So there is a lot of requirement of something that's affordable, at the same time is bundled and providing you more. And that's where you see, at least in the last 4 years, there have been 5 or 6 companies that have just grown, rapidly developing technologies under this particular bracket. And what they typically do is that they have their own CPAP generators, they have their own inbuilt airflows, they may be using bubble, they may not be using bubble, I'll come to that. They have their own humidifiers, and the alarm systems, the integrated interaction between providing you data, providing you intelligence, I think that is where a lot of the technology advances are occurring. And if you can also see, going ahead, the cost of this middle cost area is somewhere between 1 to 1.8 lakhs. Otherwise, it's 3 to 5 lakhs, or there's something as simple as, something that you can make on your own. There are a lot of companies, there's the Pumani CPAP, Equalize Health is making something, there's a Polite CPAP. We have companies like SANS from Inaxcel that is making the CPAP, and Phoenix and CPAP. I think 4 of them, Equalize Health, SANS, Phoenix, and Fisher and Paykel, they're all here in this conference. I encourage you to look at these technologies closer, because I cannot share their details over here for valid reasons, but you can obviously go and visit them and see what are the kind of features that they're providing and whether that can help your patients and your facility centers. Yeah. Yes, sir. Good. Yes, sir.
One small token of appreciation. I want everybody just one small round of applause to Nuri Suryanarayan.
Oh. Sir. Oh. Thank you. Thanks.
Thank you. Madam, did it? Okay. Why I am giving? Anybody? Okay. See, today if we are standing here, sir, number one, it's all because of Suri Narayana sir. He is a very senior man. Number second is, just 1 month back we were having zero amount. 1 month back we had a zero amount. He is the second person or third person, I don't remember exactly. When I called him, he told only one thing, Dinakar, neekem kaval, what you want? What you want? I told, sir, you are senior, can you just sponsor our NIV workshop? Antena, that means that's all. Okay, what is the things? I asked one ex, he never even asked me, is it that much amount? Or you want anything? No conjuicy, no bargaining or anything. He told, come on. He called somebody. In 20 minutes, money was there in our Neocon account. Because of him, I am telling, even all the workshops has been sponsored. I am not telling this, I am proud. Just I am really emotional I am becoming. Just 1 month back, now we are able to raise more than 2 CR. Like that, there people are there to raise really 1 billion. Is working with her
great, all nitric oxide, big machines, full patients. Okay, now they are level 3A accredited center. Now level 3B, if they will do the cardiac surgery or something, they are due for this. Okay, thank you very much, sir. And one more thing, sir, about sir, just 2 minutes. Anybody else who doesn't know him? Anybody who knows see, because I don't know TikTok, I don't know Flip, Facebook, because I don't know how to open Facebook. But TikTok, God only knows, I don't know. Everybody, he is Dr. Jagdish Chaturvedi, he is ENT doctor. Okay, he is like stand-up comedian. Today in the presidential dinner today, we requested sir to have at least 45 minutes. Please, I request everybody who are having time, please join with us in the evening. We request, just listen to sir. More than anything else, he is a ENT surgeon, and his innovation, sir, there is one more innovation doctor. She was Kayatri sir, Vivekananda, and our neonatology, we have seen only one doctor in innovations. And he is really, we are, so he is also into innovation, more than 200 innovated, some patented things under him. So one big round of applause for him. And as usual, I think so Sangamitra will introduce all our speakers. Okay? Sorry to trouble.
All right, before I close, this bubble CPAP has been traditionally being used. Most of our nurses are trained in bubbling. We also heard in some previous talks that, the device stops working, look for bubbling. But a lot of technologies that are coming up now are moving away from bubbling, but having their own inbuilt airflow system. And there have been studies coming out, this is just one of them, but there is a lot of debate. I know it's on the fence, but there are some studies coming out saying that they have equal efficacy in the care that is being provided. This is one such RCT. Now, there are certain areas where innovation is being particularly looked at. One is compatibility. And when you have a bubbling system, it's very hard to make it compact. It's very hard to allow transportation, because you have to keep a level that has to be maintained, and while traveling and while transportation, it's not always very easy. That's why technologies are moving towards having their own inbuilt airflow system so that they can be compatible, they can have more portability, they can have more easy transport, like they can have lower weight, they can be more durable while being transported in ambulances or even in private vehicles on all sorts of roads that may not exist in many rural parts. And independent functionality, battery backup is becoming something that is a requirement which is not really looked at in the high income countries. But here you may have battery backup requirement for 4 to 6 hours where the device can run independently. And especially at times of pandemic or at places where you need to provide home care or create isolated camps or even create mobile vehicles for care, you need some systems that will provide you that battery backup and allow monitoring and all of those things with ease of use. But the area where I think we need most amount of innovations, and it is not happening for some reason, is basically in the interface and the circuit. And we also saw, Dr. Srinivas present, images of babies having septal damage, and that can, cause a lot of problems, even at that time, but also going forward with their growth. And for some reason, even though there are a lot of these companies developing technologies focusing on the other aspects, but the interface for some reason is not being cracked in a way that it can be safely used without much. Because nowadays, we may not have that much of nursing care and that much of constant monitoring for babies to look at whether the circuit is fine, whether the nasal septum is injured or not. And sometimes we have seen in some smaller hospitals that 3 babies, 2 babies in just, one particular bed. So this is an area where if, doctors like yourself who spend day in, day out, understand the nuances of what can be done to make the interface better, I think there is a lot of scope of innovation there. There may not be much development that will be possible after a point with the technology alone, because CPAP being a very straightforward thing. So with that, I would like to give you a small token for your time. This is a small initiative to update our knowledge on rheumatic fever and rheumatic heart disease that pediatricians also see. You can get a certificate from Stanford Biodesign by scanning that QR code and taking part in a questionnaire that just takes 5 minutes of your time. You finish that questionnaire and you get a certificate from Stanford Biodesign as a token of appreciation of upgrading your knowledge. This is an innovative questionnaire. You don't really have to prepare for it. Just go through the questions. You learn the answers along the way, and it just updates your knowledge. So you can just scan this QR code or take a photograph of this, and if because of the size of the image it seems to have changed, if the QR code is not working, you can please meet me at the end of this session and I'll share the link with you. With that, thank you very much, and over to our MC. Thanks. Thank you.
Little HFNC, that is heated high flow humidified.
Yeah, thank you. Let me check. So good afternoon. After a long break, I think it's a transition time from AM to PM. So we are also changing from older people to younger people, from some CPAP to HFNC. So all transition is going on. I think now also Team India also they have changed. Virat Kohli, we knew that okay, some controversy is going on. So we are also in a controversial phase. So what is the next? Because Dr. Chaturvedi also told, even if Sir Srinivas sir also told, like so many things are happening because of CPAP. We know that okay, since last 2 decades we are hearing CPAP, CPAP and CPAP. So this is good thing. We have switched up from invasive to non-invasive ventilation. And from non-invasive, what are the other things? Because you are every day, we are seeing every day, one CPAP injury will be there. If you are taking care of a 20-weeker or less than that, they normally used to stay with you for a couple of months, not 1 or 2 days. Out of that also, how much time you have taken and how much good care we have given through the non-invasive ventilation also, they normally used to see some point of time there will be some injury or dependency on CPAP. So can I do something to make sure that I am not doing any harm to the baby? Like last 1 month before, when I discharged one child, a 26-weeker 750 gram, and they came on follow-up. So they are asking me, sir, here the injury is there and some scar mark is there. What is going to do next? So what is the answer? Because I have thought, okay, they will appreciate me. I have survived a 26-weeker baby, 750 gram, and at the long term they are coming with a follow-up. So I am very glad to see the baby is now 3 kilo, but with a scar mark. And that is a female child. What sir is telling that they have to spend all 2 crores of rupees if the dowry system is there. So I am not encouraging that, but to make sure that okay, can I do something for that type of baby? So can a alternative is there for CPAP? Is the CPAP HFNC I am going to talk on 30 minutes. Is it an alternative or similar, or is it inferior or non-inferior? I am going to talk on that. So my talk will be like mechanics, because this is a different type, it's not like a CPAP. So what are the mechanics and devices, what are the indication, what the initiation, what the monitoring and maintenance we require, weaning and removal, and what are the evidences, current evidence in supporting that HFNC. So as I know that okay, this line is very faint, but the CPAP or NIV, and on other side is HFNC. I am going on taking like okay, this is on the lower side, this is on the higher side, but in my end of the topic you will see okay, something is better than this one. So what is the drawback of CPAP? As we know that okay, the bulky interface causing the more injury, and the need of prong. It's a different type of prong. People are trying on, all the innovation is going through the prong, but still unable to mask and prong. It might be hard, firm, soft, short binasal prong, or it's a very thin prong. But still that so many things are happening and it's getting the injury because of the interface and because of the bulky nature of the CPAP. And another thing is the feeding intolerance. When I am talking about 26-weeker baby, 27-weeker baby, most of the time you will see the CPAP belly. And that is making us to make sure that okay, it's not a feeding intolerance, it might be NEC, something else, but if landing on might be a CPAP belly. So what I will do next? And another thing is we are moving from the quantity to the quality. Quality means a mother-centric care. So what will say, the mother will come and ask, can I do something? Can I hold my baby to KMC? So in a CPAP, how can I do a KMC? Many people are trying on CPAP, KMC they are doing, but is it feasible? It's not like okay, so much things like they're coming out, CPAP prong is coming out, it's not delivering, baby desaturating. So what the next? Can I try on some other things, what is called HFNC? Is so simple or it's difficult? So I've gone through that these things is making a more advantageous than a CPAP when the baby required other than CPAP. So we can see that two baby, that baby is bronchiolitis, some are nearly a bigger baby, he is very happy with HFNC, and another slide is the mother is very happy. So we want both, the baby has to be happy and the mother has to be happy, so that the outcome will be good enough in a long run. So is it a new device? The HFNC what we are using is high flow heated humidified nasal cannula. So we are using cannula since long. When we were a MD student in 2006, what sir also my senior also they are telling okay, we are putting oxygen prong. So and for a 1 kilo child the oxygen prong of 1 liter is might be high flow for them according to the calculation. So because tidal volume is 6 ml, if you count the minute ventilation it's almost all 1 liter. So if you are putting a 1 liter oxygen it will be high flow for the 1 kilo child. But it's not a new thing we are putting, but only bypassing the humidification. Is it so same thing or is delivering something else? So I am going to talk on that because what is happening here is in a low flow system, if you are putting that oxygen and you are not able to get that much amount of oxygen. If you are putting 100%, it might be diluting because of air entrapment and getting air and oxygen mixture, and you are getting not desired oxygen, how much you require. But if you put a high flow system, you are nullifying that air entrapment. So how much you are giving the 100%, it might be getting to the 100%. That is called high flow. So for a 1 kilo baby, if you calculate this is a 1 liter is high flow, definitely give 100% oxygen. So that is the fallacy between a low flow and high flow. So high flow, how much will give the oxygen, the desired oxygen will get. So FIO will be same. And second one, the lung disease. How much you are getting, the support you are getting or not. Is it generating any CPAP? Because on the introduction, Sanghamitra told that is CPAP is not delivering. So I am just contradicting in my the slide. So I am going to talk on that, how much CPAP is delivering. It might be equal or more than that if you are giving inadvertent flow. And so many studies going on since 2001, the final study, and now it is going to the almost 2020 or 21. I am just going to see that okay, many evidences has come and the popularity of HFNC has gone to that high that people are fond of using HFNC when buying a machine for a unit. Last 1 month before we buy a machine which is a dual CPAP and HFNC. So you will be loved to that one because HFNC will be equal to might be a CPAP or more than that. So all the study from 1993 to 2013, they have seen okay, pressure device is variable, unpredictable, that mouth opening, if you are putting a CPAP, many people have put on like mouth to close it out so that you can deliver CPAP. But optimal PEEP, how much is there, even if so many evidence are there in a CPAP, still we are unable to measure, even if that is baby to baby is varying, the baby position is varying, that depend upon the nursing care, how much the nursing care is taking care, are they occluded or not, how much is the neck flexion is there or not. So it's not that much easy when a CPAP we are giving also 6, it might be 5 or 4. We know that one. So all the clinical study what they have seen, like flow rate of more than 8 liter up to 6 to 8 liter, it developed generally like CPAP or PEEP, and it will be like on the high flow system will develop like minimal distress and it will be better efficacy. And the same thing also when the 2007 or 2001 somebody published, the HFNC group is having decreased nasal trauma, increase extubation failure is less than 26 more, but more than 26 week it is equal to efficacy. And half HFNC failure rescued with CPAP. So, we put a primary HFNC, then we might have a switch up to CPAP, that also good thing to do it out. And after that many evidences in 2007 in Journal of Perinatology, high flow cannula as a device to provide CPAP, so distending pressure. They have also seen like okay, if you are giving more than 3 liters of oxygen, they also generating a PEEP equal to a CPAP, how much you are desired. So now the popularity is from 2000, it is gaining up to 2016 or 18, it was on the higher range. And because of the corona, I think in elders who is taking care of an adult, they have bought all the HFNC machine. If a corona pandemic will out, the HFNC machine, I think it will come to the NICU. I am sure that HFNC machine will come to NICU because we can use that one in a proper way. So what are the things is happening? Because the CPAP is, I think the slide is not clear. So it's a extubation failure, we can give post-extubation support, alternative to a prolonged CPAP or as a primary outcome. The 3 modality you can use at a HFNC. I think first one is a good evidence, I am going to see that one. The post-extubation failure rate is very low if you are putting on to from extubation to HFNC. And alternative to a CPAP also, that is a good if is delivering more than 28 weeks baby, or as a primary treatment for RDS, that is also evidences are there. So I think slide is not moving. Next slide. So this after stabilization of baby, after delivery, I think you can go on to primary treatment as a RDS if your Silverman score is more than 4. If you are trying on CPAP, better try on HFNC. If it is failing, then you can go on to CPAP as a switching mode. So that also another mode is there, and people have got a success rate of almost 60%. They have nullified that CPAP is not required if you put an HFNC in the primary mode. And same thing like alternative to prolonged CPAP, if you are 26 week or 27 week baby, if you are ventilating for a long time, you have to come down like okay, weaning of the CPAP. Some point of time will be stuck with some CPAP of PEEP of 5 or FiO2 of 30% because they are on the evolving BPD phase. At the same point of time, we can try on HFNC so that it will be good enough on the other side because qualitative and the nullifying here. Just go on, no? Next. Yeah. So this is from invasive to non-invasive, and all the 4, I think Yoder's, they have done almost more than 22 weeker baby. Wilkinson, Collins and Manley all have given a primary mode or post-extubation failure. They have seen no difference between a CPAP and HFNC. They are equal efficacy, and the significant reduction of the nasal trauma is very high, and the adverse outcome out of CPAP is very less. I think we have to switch. So these are all from the good journal. Yes. So this is a primary treatment. So when you are using as RDS or you are using as a CPAP or HFNC as a primary mode for RDS of less than 28 weeker baby or more than 28 weeker baby. The first one, if it is more than 28 weeker baby, the equal efficacy is there. If you are less than 28 weeker baby, the chance of HFNC failure is very high. But even CPAP failure also 60%. So you can see that okay, HFNC is 80% failure less than 28 weeker baby compared to a CPAP which is 60% failure rate. But more than 22 weeker baby, we can try on HFNC because all the evidence, I think from the Murki sir who has done in 2018 also, they have seen HFNC is less than 28 weeker baby is not a primary mode, you have to abandon, but more than 28 weeker we can give a trial. Then we can go on to crossover, switch up. It's working. Yeah. So all other things, I am quoting from that one, like nasal trauma rate is very low in HFNC mode, and the other thing is where the things are coming out. So what HFNC is doing? Are they a closed system like a CPAP? No, it's an open system. It's a high flow rate. You have to give a high flow rate with a good humidity and temperature. Then it has to meet the demand of the inspiration, might be higher of the inspiratory demand. So what are the mechanics? I am just talking on CPAP. It's a distending pressure. During expiration, you have to switching off. So baby has to fight during the time of expiration because he has to breathe out, and you are giving a PEEP, distending pressure from the outside. But in this system, it's not like that. So it is inspiration also helping out and expiration also helping out because it's a open system. In expiration, it is giving some time and there is a leak between the cannula. So you can breathe out at the time of expiration. But during inspiration what is happening? Because the inspiratory flow rate is generating high inspiratory demand and you are just nullifying your demand by putting the dead space out of it. So you are just washing your dead space. The oxygenation and carbon dioxide is coming to a nearer point to the alveoli. So oxygenation better and the work of breathing is getting down, improvement of oxygenation and carbon dioxide is better, and by putting a heating and humidification, you are just doing that improvement of the compliance, so that the less chance of injury is there to the alveoli. And compared to the all four, I think first one, the if it's high humidification you are giving, you are just nullifying that excessive demand, metabolic demand, you are decreasing. Then wash out of the airway, so dead space you are coming down, thus oxygenation better. And if you are putting an inspiratory flow on the higher side, so dynamic compliance is better. So maybe the collapsibility is on the lower side. At the same time, if you are getting entrainment of the air is not getting, so your desired oxygen, how much FiO2 you are giving, that is you are met the demand of the oxygen requirement. So all the things if you combine together, and during the I told that same that switching off and switching on between the expiration and inspiration, there is a fluidic flip. So it is more on HFNC time, is a Konda effect called, that is also getting better. So better oxygenation, better carbon dioxide wash out during putting on HFNC. In a nutshell, what the things are doing? So one is, first is washing out the nasopharyngeal dead space, so decreasing the dead space, so work of breathing is less. The reduction of inspiratory resistance, by putting nasal resistance, you are putting a high flow, you are just nullifying the resistance, and improvement of the conductance and pulmonary compliance by putting a CPAP, dead space, so and reduction of metabolic work, and positive dystonic pressure, what I am going to tell on the next two slides, how much pressure is generating. So in this slide, you can see that on the left side, on the y-axis, that is a pressure generation, on the x-axis on the left side, that is a flow. So if you are putting on 2 liters of oxygen or 2 liters of flow, 4 liters of flow or 6 liter flow, you can see there is a pressure generation between 0 to 4 in first if you are putting a 2 liters. If you compare to a 4 to a 6 liter, then definitely on increment of the pressure required, and what is the pressure generation is 4 to 8 liters. So they have compared like, okay, if you are putting a 4 to 8 liters of flow in a HFNC, in a small baby, in a neonates, then normally is to deliver almost PEEP of 4 to 6, which is our requirement, 6 to 8 even if we have gone to up to that, but people have not tried beyond 8 liters. At the same time also, if this study, I got it, the archive of disease, you can see a 1 kilo child, less than 1 kilo child, if you are putting a 2 liters, then also that mean pressure is generating almost 3. And compared to here, if you are putting a 6 liter, if less than 1 kilo child, is almost delivering up to PEEP of 5. So 5 plus minus 2, so might be 4 to 6, 4 to 8 he is generating if you are putting a flow of 6 liter for a 1 kilo child. And compared to a 1500 gram, if it is almost delivering on the lower side. So your desired set pressure almost 4 to 6 or 6 to 8 you are getting if you are putting on HFNC flow of 4 to 6 liter or 6 to 8 liters. It depends on how bigger baby you can put at that lower side, you will get less pressure. If a smaller baby you are putting on bigger higher flow, you will get a high pressure. And another one is the nasal prong, how much prong size is required, how much it will fit into that, because I told it's a open system. You are just putting that flow and you have to come out from the nares. So this flow and the nasal prong size, what I am compared, I think this one, the first one is like 3 millimeter prong and we are getting 3.7 millimeter prong. So you have to choose a prong size. So I will get that color code, what the prong size will be there. Okay, it's my next slide is there. So this, if you put a prong of smaller size and it will fit into more than 50% or 60%, then normally you should generate more pressure because it's occluding more on side. If you are getting on 50% to 60% of our occlusion of the nasal nares, then you will get a desired pressure of 4 to 8 PEEP. So it's depend upon the prong size also, depend upon the fitting, how much fitting into that. If it's more than 50%, you are occluding more. So your chance of PEEP is high, dystonic pressure is more on high. So if you go on to that initial on the second 2 lines, if you are putting on 50% to 60% of your nasal nares and you are putting the prong size of 50 to 60%, you will get a generation of PEEP of 5 or 6. So it depends upon the size of the prong, how much you are getting into the prong size and what baby of size if you are putting into that and how much is fitting. So device As you know that this is very simplest form of the CPAP machine. If your expiratory limb is coming out, taking out, then it will be an inspiratory limb, and if you connect to the nasal prong of this one, I will put into demo. So this will be almost a similar size, a inspiration size and inspiratory limb. There is a prong of inspiratory proximal temperature probe. Then after that it will start is a prong. So there is no expiratory limb. So all the things will be inspiratory limb. There is a blender and the flow will be there, and flow will come to the baby directly. So there will be no that much of bulky that interface will be there, and many things you have to take care. So it is a very simple thing what you are going to do. And there are many types are there. If a Physiological, there is OptiFlow, what you are going to use on this one, and Vapotherm, what is up to 2016 that was delivered, but because of many delivery system problem was there, and the chance of infection Rastronella is there, so they have stopped it out, Vapotherm. And now the Airvo machine and Physiological 850 system we are going to demo in the next. And we know that HFNC also can be delivered in some higher end of the ventilator. They are also putting NIV, one mode will be HFNC. So we can go on to that one also in ventilator also, the NIV how it is getting HFNC. So coming to the interface, if you are putting an interface, there is two types of interface. It's a binasal prong, might be it's a adhesive tape will be there, or other one is called Ram's cannula. It's a very simplified one, the Ram's cannula, you just put into that one. So on demo you can see how much interface and what is the size of interface, but make sure that okay, your interface size should be good enough so that it will generate on the optimal flow and optimal pressure. So that color code has to be there. So it is always on color code. In a premature baby it will be on the on the left side, the prong, then yellow, then violet and green. So nothing to be on other side, because you have to make sure that okay, when you are choosing a baby, small baby or bigger baby, you have to choose this prong of appropriate size, so that no mismatch will be there. If you give a large prong to a smaller baby, definitely it is definitely going to cause more injury and more pressure injury. So this prong also have a design like that, they will give that much of flow. So it's a, if a premature baby, maximum flow will be gone to 8 liters, beyond that it will not work or it cause injury. So if it's go to infancy, till up to 10 kilo, it will deliver up to 20 liters. And pediatric age group, we can go on to maximum of 25 liters per minute. So there has to be color code. So indication, contraindication almost similar. I think for a premature baby, it is RDS, Silverman score of more than 3, recurrent apnea, post-extubation. The contraindication are there too. If you tracheomalacia, never try to put on HFNC, even if CPAP. Even if phrenic nerve palsy also there, don't try to put on. So most common indication are there, post-extubation, recurrent apnea if the baby is getting apnea, or RDS if Silverman score more than 3, try on HFNC. If it is failing, put back to CPAP. So there should be a protocol in unit so that we can go on to on the CPAP or HFNC. So where I am putting on HFNC, this might be oxygen therapy, low flow therapy. If you are going to high flow therapy, just choose a HFNC. If it is failing, put back to CPAP. If CPAP is failing, then bi-level, then go on to mechanical ventilation. So always go on trying at the HFNC, not to jump it out to CPAP. In my, then term baby, if it's pneumonia, most common congenital pneumonia is coming out, and meconium aspiration also people have tried and they got a success also higher side. So what the contraindication, as I told, there will be any congenital anomaly on the higher upper airway. So choanal atresia, tracheoesophageal fistula, CDH. So don't try on putting HFNC, we are wasting your time. So and another baby who is on multiple inotrous or cardiorespiratory instability. So don't try on putting an HFNC. Then initiation, how I will do a starting a HFNC initiation, what are the things I have to look at. So connect to a pulse oximetry, how much saturation is there, because from the clinical point of view I have to see okay, what is the baby condition at the starting point. The right size prong, interface and device, I have to check other my everything is working or not before starting an HFNC, because it is not like wonderful drug. If you put it out, you will get the results. It will be step by step, baby will get into improvement. So I have to check it out at the starting point, what is my FiO2, what is my saturation, how the baby looks, and now how the baby is improving. And the flow and FiO2 at optimal level, because flow is more important because it is flow driven. So if you are putting in flow, you have to give definitely how much flow required for the baby, 4 to 6 liters or 6 to 8 liters, and what is the FiO2, how much I can go beyond. So more than 40%, don't try on FiO2, and up to check it to 40% or 50%, and baby response, how much the baby is getting. and check the circuit, because circuit is more important, because there is nothing. If a circuit is disconnected or circuit is not working or there is filled with water, then it might not deliver that much of fluid what is desired. And monitoring, as everybody told on CPAP, so the same monitoring, the monitoring is the first and foremost, because if you are putting a baby on CPAP or HFNC, the most important, the baby has to be monitored in a continuous way. So when I am putting HFNC, because I know that okay, the HFNC is going to fail, I have to sit with the baby. So don't leave the baby putting HFNC or CPAP. That is the first and foremost. To succeed it out in an NIV, you have to be there if your baby is RDS, because it's a dynamic lungs, compliance is going up and down. So always try to think like, okay, can I sit there? If I am starting my point, even if fellows or my DNB students are there, I never used to leave them out. I will sit for any half an hour to 1 hour to check it out my machine is working or not. If it's deteriorating or something, I can do better, because I know better than machine. Okay. So the baby airway, I have to check it out, the baby condition status and airway, how it's going on. Then prong size, it's fitting or I put a prong of appropriate size or not. Then circulation, circuit, the condensation is there or not. Is there any leak? High leak is there. Then I have to check my machine. So in machine, what I'll see? The flow, FIR2, humidification and any other complication happening to the machine. So these all things, because flow is mandatory and what you set a flow is delivering or not. Then FIR2, how much FIR2 I am getting because of blender, I am getting or not. Then humidification should be there if you are making a success of this one. Then clinical monitoring is, I know that okay, clinical monitoring has to be there. Every 10-20 minutes, according to CPAP, sir is telling very nicely, 15 minutes you have to see the saturation index and how much saturation is there, how much FIR2 requirement is there, what is the chest retraction, chest expansion is there, air entry if somebody is checking out, it's very good. And the other things is how the circulation, hemodynamic things are there. So urine output, abdomen distension, the bowel sounds is good enough, and the baby neurologically has to be fit enough, because baby is completely paralyzed, or baby term baby, if HI, if you are trying, baby is on like that breathing effort is not good, it's not going to help. So baby has to be good enough, neurologically good, cardio hemodynamic stability is there, and you try on just playing on FIR2, PEEP and flow when the baby clinical monitoring you are doing, and do an ABG and X-ray when it is required. It's not mandatory, ABG is every time you do it out, because now we are changing from invasive to non-invasive. Even if for a ABG, what you will see? You will see the pH, you will see the PO2 and CO2. If you are putting on PO2, the saturation telling out is what is the PO2. Only CO2 we cannot measure. If baby is good enough, even if you can think of CO2 might be good enough, if a baby breathing is good enough. And this one everybody told the silver score monitoring chart, because every time to time, initial part every 15 minutes has to be there for HFNC, even a CPAP. Then after that baby improving condition, you can go on to frequency, you can change from half an hour to 1 hour or something. But it has to be there in every NICU, every corner, even a baby also there, the monitoring chart has to be pinned with that one, the baby side. And the monitoring the airway, because you know that okay, this is not beyond the airway. If it's previously like if you are putting on the pre-airway. So if you are putting here, then there has to be adequate airway pressure to be generated here. It has to be patency. So if no patency is there, definitely HFNC or CPAP is going to fail. So make sure that your patency from the airway has to be there, and you are just take care of the nostril every time. You are just suctioning, putting sterile water on ends, and your suction, you are not making much more injury. If you are putting more on like every 1 hour or 2 hours, and you are not checking the pressure, how much is generating the pressure, you will get more injury and getting a more blood. And adequacy is like HFNC, because you know that clinical, your equipment will be good enough, because baby should be comfortable, baby should be on improvement trend, minimal retraction, grunting should be there, baby hemodynamic stability will be there, and baby will be not in recurrent apnea, and saturation is making on normal side. That initiation I quoted from a guideline, concession guideline, that how to initiate. You just start on depend upon the size of the baby, what is the weight, 1500 gram or less than that. You start up initiation flow of 4 to 6 liter. As the size will go on, you can go up to 6 to 8 liters. So in a term baby, if you are putting that one, try on 6 to 8 liters. FI to always keep on banded it at 30 to 40%, not beyond that, and see the respiratory rate and work of breathing. And by how much will start and how much we escalate, don't try to play on FIO2, don't go beyond 60%. So 30 to 40% will be enough. If you are failing and if you are tried up to 1 to 2 hours and the baby is not improving, just de-escalate or go on to escalating the therapy to CPAP. So that will be better. You can time save and consume the time, baby will not be further deteriorated. If a baby is improving, so if a baby is improving up to 24 hours, put on HFNC. Don't try within 24 hours, so negating the flu or FiO2. FiO2 you can play with your saturation, but if a flu is there, just continue for at least 24 hours. Then after 24 hours, see again, baby clinical monitoring should be good enough, baby is hemodynamically stable, then you can play with your flow by decreasing 0.5 liters per minute every 12 to 24 hours if baby is less than 1500 gram. If baby is bigger one, you can try quickly 6 to 12 hours, or even less than 6 hours, we can try on weaning of the baby from the HFNC. And how much will go on, like what is the minimal flow will be there, so that we can discontinue. So the minimal flow depend upon his weight. If is approximately what is the baby weight, you just discontinue at the same liters. So if you 1 kilo child, you just discontinue 1 liter. If a child is 1.5 kilo, you just discontinue 1.5 liters. So like that you can take a call when you are trying to wean off from the HFNC. So then weaning is a gradual process. You know that okay, this step of FiO2 should go down by 5%, even if people should try on 1, 2, 3, 4, 5, 1 every time. And that flow I told, like every time 0.5 liters per minute every 12 hours. If his baby is very small, you try on giving 24 hours. And disease process has to be improved. Without the disease process, you are showing X-ray, ABG and clinical monitoring, the baby is fine, then try to wean up. Then next one is the flow. When to remove HFNC, as I told, with the baby size, depend upon the baby size, you can change. So what is the procedure after HFNC? I told okay, this airway should be patency. So make sure that okay, you are giving a nasal suction, adequate interval, saline nebulization if is required, watch for apnea, tachypnea, retraction and frequent change in position. And you can hold the baby. When the baby on HFNC also, you ask the mother if the baby is hemodynamically stable, the mother can do a KMC. So that will give a hemodynamic stability also when putting on HFNC. Then failure of HFNC as I CPAP, the same thing, continue retracting, continue grunting, recurrent apnea, saturation not maintained, PCO2 is beyond 55 or baby not tolerating CPAP also. When the baby is on CPAP, he is failing, don't try on putting HFNC because it is inferior to the CPAP group. So you try on initial part, but not after trying on CPAP. Okay. So reason for failure is inadequate flow. First check your flow will be good enough, and worsening of the respiratory or cardiorespiratory or neurological status. If the baby is neurological not stable, cardiovascular not stable or respiratory wise worsening, might be reason of failure of HFNC. Next please. Slide please. Yeah, so if the baby is failing on HFNC, then you go on trying on CPAP, might be switching from the HFNC to CPAP, or you might be trying on intubating. So before intubating or putting on to CPAP, check sure that okay, your HFNC you are given optimal, your flow is optimal, your prong is optimal size, baby hemodynamic stability is there, then we change to HFNC to ventilate or intubate the child. Otherwise don't try. Can you give some more time on HFNC so that the baby might be improving. Okay. Next one. Just leave it out. Yeah, next. Next please. Yeah, next. So what is the evidence? I am taking quoting from the Cochrane review from 2016. So they have tried on like multiple parameter, like primary mode of ventilation in RDS, post extubation, what is the HFNC role and CPAP role, and that other one is a treatment failure of CPAP. So high flow nasal cannula for respiratory support in preterm baby. So this is a Cochrane review by Wilkinson. So what they got as a primary mode, you can see this one on the last one is not favoring that HFNC is a primary mode. So CPAP is better, but some people had got in Yoder's, they got like HFNC is better than CPAP, but because that group is more than 28 weeks. If a subgroup analysis will see that who has got a success rate, they are on the higher side, 28 weeker to 30 weeker. But other people who have started on HFNC as a primary mode, it was on 26 weeker, 27 weeker, so they got on the other side. So results was not in favor of them. But if you see the extubation failure rate, if HFNC versus CPAP, they got HFNC is better than CPAP when putting, because already the baby lungs was very good. and the baby complication was on the lower side. So when putting on CPAP or HFNC, HFNC has good gut result than CPAP. And same thing like okay, prevention of extubation, other things, they are on the as per. So might be HFNC or CPAP, you can go on that one. So rate of reintubation rate are very less when you put on HFNC compared to a CPAP group. So reintubation was on the lower side when put on HFNC after extubation. And this one like high flow nasal cannula versus CPAP, prevention of extubation, again same thing, that is on favoring CPAP because this group are on the smaller baby. So this one like okay, pneumothorax, if you are putting on CPAP and versus HFNC, the pneumothorax rate is very low when you are putting in HFNC as a primary mode. And same thing nasal trauma, we have seen like a nasal trauma is almost all minimal when you are putting HFNC versus a CPAP group. So take home message is from HFNC there, HFNC has similar rate of efficacy when compared to the other method of NIV in supporting the preterm baby, preventing treatment failure, death or BPD. So all are equal in the long term morbidity or mortality. So paucity of data is primary mode of NIV in LBW because we are not getting that much success rate in Cochrane review also. Is a preferred mode for post extubation or extubation baby who is well tolerating and chance of nasal trauma is less and pneumothorax is less. So adequate flow and humidification is a must for a better monitoring and functioning of the baby. And 50% nair or size of the prongs should be fit into that nairs to maintain a good ratio and safety of the HFNC. It's a better tolerate and a convenience to use for the baby and the mother. Thank you. So any question? Thank you.
This one is slides up and down. This is slides up and down. Good afternoon, everyone. So my talk is DuoPAP, NIPPV, other modes of these are other modes of non-invasive ventilation. So we all have seen CPAP, HFNC, and various modes of CPAP, and now we will see other mode of non-invasive ventilation, that is with dual pressure. And my talk will go as follows: introduction, non-invasive positive pressure ventilation, synchronized non-invasive positive pressure ventilation, DO positive airway pressure, and evidence for each of it, and comparison between the two, DuoPAP and non-invasive positive pressure ventilation, and which is better. So since morning we are hearing about CPAP, and yes, it is true, CPAP is a standard treatment of modality for moderate respiratory distress, even in term and preterm babies. It has well established evidence. So one drawback CPAP is high failure rates. We are concerned with the failure rates of CPAP. This study quotes failure rate of 40% in neonates with 25 to 28 weeks, and it is little less in higher gestational age, around 21%. So as the gestational age decreases, the failure rate of CPAP increases. So various studies done on CPAP, RCTs, famous RCTs, coded a failure rate of around 30 to 80% with CPAP. We are all worried about failure of CPAP once we are choosing it as a mode. So who are the babies who fail CPAP? So these are the babies who have incomplete exposure of antenatal corticosteroids, cesarean delivery without onset of labor, a need for positive pressure delivery, ventilation at delivery, and who has a bad blood gas, within first bad blood gas, and X-ray suggestive of severe RDS, And male babies are also more prone to develop CPAP failure. So do we have any alternative? Yes, definitely. Various modes are now available. So among them, non-invasive positive pressure ventilation, whether synchronized or non-synchronized, and bi-level CPAP like DuoPAP, BiPAP, SciPAP, whatever may be the name, they deliver 2 levels of CPAP, upper CPAP and a lower CPAP. Non-invasive high frequency ventilation, which will be covered in the next talk, and other modes like neurally adjusted ventilatory assist. So I will confine my talk to NIPPV and DuoPAP. Coming to NIPPV, so simple effective mode of respiratory support which augments CPAP with superimposed inflations like PIP. With CPAP, along with CPAP, it gives inflations, means it mimic invasive ventilation. So various mechanism of actions, these are all similar like CPAP. Extra which it gives is it decreases the work of breathing. It improves thoracoabdominal asynchrony, increases tidal volume minute ventilation, and it decreases PCO2 levels, carbon dioxide. The indications and the contraindications of NIPPV, DuoPAP are almost similar to CPAP. So preterm RDS for prevention of post-extubation failure and apnea of prematurity are the most common indications which you use NIPPV. So this is how the monitor of a NIPPV looks. Here we set the flow, I time, PEEP, PIP, and the rate. And here we can see the delivered parameters. Here we adjust the parameters. What is synchronized NIPPV?
They are apparently coming to check, so all of you all are requested to wear your masks, please.
What is synchronization? So mechanical inflation commencing within 100 milliseconds of onset of inspiration is called synchronization. So various synchronized various ventilators which can provide synchronized non-invasive ventilation are infant star ventilator, which is not available in market rightly, Putin-Burnett, Gulia, and SOPHI. This uses Grace by capsule. The bottom thing we can see, the blue color one, this is a Grace by capsule. They attach it to the abdomen, which detects the abdominal movement and delivers a positive pressure. And only Gulia from Italy, it uses pneumotachograph. I don't know whether these are available currently in India. So what is DuoPAP? It's a type of bi-level CPAP. Other bi-level modes available are SciPAP and BiPAP. It uses infant flow driver, which generates 2 levels of pressure, a high pressure CPAP and a low pressure CPAP at different flow rates. This is how the monitor of a DuoPAP in Accutronics look like. So here also we set a upper CPAP, which we call DuoPAP, PDO in this 8. This one is PDO. This is the upper CPAP, and this is the lower CPAP 4. Here is the time, I time for upper CPAP 0.5, and this is the rate we set, FiO2 we set. So this is also monitor of the DuoPAP in Accutronics. So PDO, what is PDO or upper CPAP? Is a maximum pressure that is alternatively applied to the previous lower CPAP. So the breathing rate is the number of PDO applied. So how it works? It increases the mean airway pressure, increases the tidal volume, increases the minute ventilation, and which improves hypoxia and CO2 retention. The differences between NIPPV and DuoPAP, both are giving 2 pressures. Then how is it different? So NIPPV mimics invasive ventilation, DuoPAP mimics CPAP, means it is like a bridging between NIPPV and CPAP. So any conventional ventilator can give non-invasive positive pressure ventilation. DuoPAP standby machines are available, and some advanced ventilators are providing this modality, but they require infant flow driver to deliver this. So we set PIP, PWP in NIPPV. Here in DuoPAP we set 2 pressures, upper CPAP and lower CPAP levels. And I time, we use shorter I times in NIPPV and relatively longer I times in DuoPAP. And the rates, we use higher rates in NIPPV and lower rates in DuoPAP. The flow in NIPPV is constant. DuoPAP utilizes a variable flow to deliver two variable CPAP pressures. So synchronization is possible with NIPPV. In DuoPAP, infant breathes independently on two levels of CPAP. Weaning, we wean PIP rate every 6th hourly once we reach a FiO2 of 30%. In NIPPV, the same upper CPAP and lower CPAP we wean by 1 centimeter every 6th hourly. And once the PIP in NIV is between 12 to 15 and MAP of approximately 8, PIP of 4 to 5, FiO2 less than 30, baby clinically stable, we wean. The same, the lower CPAP level less than 3 and a higher CPAP level less than 5 in DuoPAP, we wean. So, what does the evidence say? So, these are the common indications we use any non-invasive ventilatory support like RDS, post-extubation failure and apnea. When it is Cochrane comparing NIPPV and CPAP in RDS, so it is published in 2016, 10 articles, around 1000 infants, neonates less than 37 weeks. NIPPV reduced respiratory failure rate in RDS by 35% when compared to CPAP. And it reduced need for intubation by 22%. And there is no difference in mortality, no difference in BPD, reduced need for intubation by, this is 22%. And there is no difference between NIPPV and CPAP in various morbidities like IVH, severe IVH, NEC, sepsis or ROP. Coming to post-extubation babies, this is NIPPV comparing CPAP, published in 2010, 10 articles, almost 1500 neonates less than 37 weeks who are post-extubated to CPAP or NIPPV. It reduced respiratory failure by 30%, NIPPV, reduced need for intubation by 24%. There is no difference in GI side effects like perforation, NEC, feed intolerance, no difference in BPD. Surprisingly, air leaks were less in NIPPV, reduced by 52% when compared to CPAP, and death also reduced by 31% in NIPPV. But there is no difference in duration of hospital stay. So this is the same article. When comparing synchronized NIPPV with CPAP, it reduced respiratory failure by 75%, whereas non-synchronized it is only 35%. It is 75% in synchronized non-invasive positive pressure ventilation, and it reduced the need for intubation by 67%, whereas it is only 26% in non-synchronized. Decreased BPD by 36% and decreased air leak by 65% in synchronized ventilation. There is no difference in apnea, and other side effects it is not different. There is no difference in duration of hospital stay or death. So this is a prospective observational study done in which they want to prevent reintubation. So by using synchronized non-invasive ventilation either as an elective use or in CPAP failure babies, they have overall reduced the need for intubation by 74%. Overall, they have reduced the need for intubation by 74%. This is a systematic review comparing synchronized and non-synchronized non-invasive positive pressure ventilation. Here we can see the number needed to treat for synchronized non-invasive positive pressure ventilation for various morbidities like to reduce like BPD, NIV failure, extubation failure were very less when compared to non-synchronized positive pressure ventilation. This tells that synchronized non-invasive positive pressure ventilation is better compared to non-synchronized positive pressure ventilation. So what does the authors say? They say that NIPPV when compared to nasal CPAP reduced respiratory failure and the need for intubation in preterms with respiratory distress. Apnea is not different, not statistically significant when compared to CPAP. Coming to DuoPAP, much of evidence is not available for DuoPAP, but I have quoted 2 RCTs which I have recently done on comparing DuoPAP with CPAP. So this is published in 2015 in preterms with RDS, VLBW babies mostly. So babies who are on DuoPAP have better blood gases when compared to CPAP and less need for intubation within 24 hours, and there is no difference in other morbidities. This is another RCT published in 2021. Here 148 neonates were included, randomized. Treatment failure in the first 24 hours, it is not, first 72 hours, it is not significant. And DuoPAP only reduce the duration of non-invasive ventilation, need for repeated dose of surfactant, duration of oxygen therapy, and duration of hospitalization. Other morbidities are not significant. Excuse me, screen. So why this difference? So why the success rate of various non-invasive modes is different one over the other? Is it only the phasic pressure change or the delivery map causing this difference? We don't know at this point of time. So what is responsible for this apparent benefit? Is it the phasic pressure change or the map delivered? See this, various modes I have kept here. In one mode, NIPPV, non-invasive positive pressure ventilation, the map delivered here is 7.5, it is 9, it is 5.7, and it is 7.7. So what is causing this change? We don't know at this point of time. So to answer this, we need better studies comparing same map at least with different modes of NIV. So my take home message, consider NIPPV in neonates who are at high risk for CPAP failure, and if available, consider synchronized NIPPV, and we need more studies comparing with same map to say which NIV mode is superior. So thank you. Any questions?
So good afternoon everybody. I think I won't take much time on non-invasive HFO. So my talk will be more of interactive discussion. Let's summarize what we have learned since morning. So how many of you actually practice CPAP? Can you raise your hands? How many of you practice CPAP? Okay, I can find half of it. Sir, you practice CPAP? Do you practice CPAP in your unit? CPAP? Okay. How many of you practice NIPPV? Just now we had a great talk from Dr. Venkatraman. I think probably 30% of us are using CPAP already, probably some 10% are using NIPPV. How many of us are using nasal HFO? I can see 2 people actually, or 3 people raising hands for nasal HFO. I think probably some 5% of us must be using nasal HFO. So to be frank here, even hardly I have practiced on 2 or 3 babies on nasal HFO, because most of us are tuned to using CPAP. So if there is problem with CPAP, we are all moving towards NIPPV. So rarely we would need nasal HFO, because there are a lot of challenges. We need equipment and we need to have guidelines when we move. If somebody is comfortable with invasive, so we are not moving towards non-invasive HFO. So in the next 10 to 15 minutes, let's see what exactly is non-invasive HFO. If somebody is using CPAP, I think you need to move towards NIPPV. If you are still having problems with NIPPV, I think I'll try to convince you how important is or how efficacious is nasal HFO. So it's not moving. Yeah. Before I actually move, I would like to acknowledge, I would like to thank NNF Neocon for giving me the opportunity. I would like to acknowledge the place where I studied my MD and DM, that is PJ Chandigarh. I would also like to thank Ovum Hospital. For the last 4 years, I have been learning pediatrics and neonatology with Ovum Hospital. So, are you changing or something? It's going back actually. Yeah, we are going to discuss only 4 things. One is physiology, second is practical application. What is the evidence for its use? So, what are the future directions if somebody wants to do research on that particular topic? So, we have been learning the main purpose of non-invasive ventilation is we need to avoid the tube. Everybody would agree with me that having a tube in situ, in the short term, we are placing a newborn at risk of ventilator associated pneumonia. So, it also increases cost, length of stay. In the long run, we are mainly worried about chronic lung disease. So, we want every preterm to go home safe without a morbidity of BPD. So, because BPD is associated with poor neurodevelopment, because prematurity per se can also cause poor neurodevelopment. So, we are worried about these 2 aspects in the long run. So, that is why we always try or aim not to place the tube, or if you have to place a tube in situ, so it should be for short duration for ensure. I think now is the era for non-invasive or LISA. So, non-invasive ventilation, I think since morning we have been going through a lot of lectures. CPAP is the primary mode for RDS. I think everybody would agree with me with that, because HFNC has come, NIPPV has come, but still the first choice is CPAP. But mind you, CPAP failure is there, like as my previous speaker also mentioned that CPAP failure is to the tune of 40% if you are managing below 28 weeks. It's to the tune of 20% if you are managing anybody below 32 weeks. So, should we use NIPPV as a primary mode? I think we have learned from the previous session as well. Non-invasive ventilation, this is a forest plot from Cochrane 2016. So, in this, if you, I think the pointer is not working. So, if you see, the middle line is the line of no effect. So, do not worry about other statistics, just look at the diamond. So, the diamond actually, if it's on the left hand side, it favors non-invasive positive pressure ventilation. If it's on the right side, it favors CPAP. It's very clear from this forest plot that the diamond is favoring NIPPV for need for mechanical ventilation. If you look at something called RR, that is the lowermost corner, that is 0.78, that is there is 22% reduction in need for mechanical ventilation if you are using NIPPV for primary mode. So, we are not only interested in need for mechanical ventilation, our main aim is also to prevent BPD. If you see NIPPV versus CPAP for BPD, so you can see the diamond is touching that line. That means there is a 22% reduction in BPD, but the confidence interval are crossing beyond 1. So, that means NIPPV is not sufficient to prevent BPD when compared to CPAP. So, what summary is that NIPPV reduces mechanical ventilation, but not sufficient to reduce BPD. So, what next? So, CPAP is helping for 60% babies. What to do with these 40% babies? So, what next? I think let's try HFOV. So, why HFOV? If you look at the basic, this is the basic PV loop, the pressure volume loop. The pressure is on the x-axis, volume is on the y-axis. Everybody would agree with me that when you have the lower zone, that is a zone of de-recruitment or atelectasis, we always need to ventilate in the safe window region. If you are ventilating in the zone of over distension, will cause more barotrauma or more volutrauma. So, we need to ventilate in that safe window. What happens when we use conventional mode is that we will be oscillating between the zones of injury. We will be oscillating between zones of de-recruitment and zones of over distension. That per se would cause more barotrauma, volutrauma, and thereby risk of chronic lung disease. The advantage with HFO is that you are always in that safe window. So, this slide actually depicts it better. So, if you are ventilating with PIP and PEEP, So you can see that it's not the zero line. So because of PEEP, the line is starting above. So this is basically pressure time curve which shows PIP, PEEP as well as the MAP in a conventional mode. The lower half of the figure actually depicts when you are producing oscillations superimposed on this MAP. When you have oscillations superimposed on the MAP, you can see the delivered pressure actually is less, there is less barotrauma, and your tidal volume is always less than the dead space. Again, there is less risk of volume trauma. So HFO is more like a gentle ventilation, but it is with a tube in situ. So we all know HFO versus conventional ventilation in preterm is one of the modality to prevent BPD. HFO is able to reduce BPD only by around 10%, but still HFO is better when it comes to BPD, marginally reduces death or BPD when compared to the normal conventional mechanical ventilation. So if you have to combine CPAP and HFO, the answer is non-invasive HFO, because CPAP is a non-invasive interface, increases FRC, allows oxygenation, while if you are using a HFO device, there is no need of synchronization. Although there are controversies with this statement, but HFOV actually causes higher carbon dioxide removal and less volume or barotrauma. I think this we saw in the previous slide. If you have to combine both, then one of the modalities non-invasive HFO. So we have come to the end of physiology of non-invasive HFO. So let's see how do we practically apply non-invasive HFO on the ground. So I think we have heard about bubble CPAP in the morning. Bubble CPAP, as we are all aware, the bubbling will actually cause some oscillations on the pressure. Is bubble CPAP similar to non-invasive HFO? It's not entirely same, it's actually completely different. Although the similarity between bubble CPAP and non-invasive HFO is that a bias flow actually generates positive distending pressure with oscillation superimposed on the tidal breathing. So although the similarity is the flow or the distending pressure to maintain FRC, the difference is that bubble CPAP can actually produce only smaller irregular frequency of oscillations, smaller irregular, while non-invasive HFO is able to provide regular and larger frequency of oscillations. And problem with bubble CPAP is that there is no active expiratory phase. In a non-invasive HFO, we are able to provide a negative pressure at the end of expiration, so the expiration becomes active. And MAP generated with bubble CPAP is lower. Although bubble CPAP is better than ventilator CPAP, but non-invasive HFO, it is not similar to non-invasive HFO. So apart from understanding that, let's look into the importance of nasal interfaces. So the main goal whenever you are using a nasal interface is to provide comfort to the baby, and another goal in non-invasive HFO is that we should not reduce the or lose the pressure. So our aim should be not to reduce the dampening or pressure loss whenever we are delivering HFO through the nasal interface. Most common modality used is nasopharyngeal tube. So we use ET tubes as a nasopharyngeal tube to deliver nasal HFO. So this was in the past, but over the last 3 to 5 years, people have moved towards short binasal prongs. So concerns with nasopharyngeal tube is there is loss of compliance through another nostril and the resistance. Binasal prongs and nasal mask have been used with variable success. Another importance is that nasal diameter. With HFNC, we learned that the nasal diameter should be at least 50%. Here, larger the nasal diameter, so better would be the efficacy of non-invasive HFO. So after understanding these two practical applications, so let's look at how much to provide settings. So nasal HFO has been used in these 3 settings. In the setting of respiratory distress syndrome, post-extubation, BPD. So the first column actually reads about MAP, delta P, frequency, I time. Although it looks like a complicated slide, the I time is similar actually. It's 50% across all the settings. Frequency, generally we start at 10 Hertz and then we titrate. So if you look at delta P, some authors have used until they get upper chest vibrations, but some authors argue that the primary intention of nasal HFO is to cause carbon dioxide washout from upper airway. The upper chest vibrations is not necessary. We generally start somewhere between 25 to 50. The MAP would be same as CPAP, or you can use a MAP at least around 10 centimeters. So summary of this slide is that start with 10 MAP, delta P somewhere between 25 to 50, frequency of 10 hertz, I time of 50%. So it's very simple there. So this was just a case study of a 25-weeker who was day 35, who was on CPAP, had very high carbon dioxide. So the authors actually have tried NIPPV there. So you can see on the left hand side it's a PaCO2 and PaO2. The PaCO2 is the colored one and PaO2 is the dotted ones. So NIPPV actually had a PaCO2 of 80 while PaO2 of just 30. After 2 hours the authors have tried non-invasive HFO. So non-invasive HFO actually has improved the PaCO2 to 40 after 2 hours, PaO2 to above 50. And the pH could be brought down, the triangle one, the tip of the isosceles triangle, that is 7.35. So this was just a case study because non-invasive HFO is still in earlier days. The first application of non-invasive HFO started somewhere in just 1998. In 2000 actually first they have started a first ELBW baby on non-invasive HFO. So if the evidence, I think evidence is from just last 20 years, let's look at evidence and safety. Does it really work on ground if it's good on books? So this actually is a meta-analysis from 8 trials involving just 460 odd babies. So this is again a forest plot comparing non-invasive HFO versus CPAP. You can see the diamond is favoring non-invasive HFO in removal of carbon dioxide. So it is statistically significant. Is it clinically significant? Always whenever you are addressing a research question, you need 2 questions to answer. Is it statistically significant? Is it clinically significant? So statistically yes, clinically if you see the mean PaCO2 levels varied between 35 to 54 and on the CPAP side it varied between 40 to 50. So clinically it may not make much difference for us on ground if you have a PaCO2 between 40 to 50. So it may be statistically significant, not clinically it will be I would say similar. So more important for us is need for intubation in the short term. You can see the diamond is on the left side again favoring HFO. There is 50% reduction in need for intubation if you use nasal HFO compared to nasal CPAP as a primary treatment for RDS. This data is only from 8 studies involving 460 odd babies. That means we need more data, larger randomized control trials to prove further efficacy. So if you look at the safety data, the big challenge with all these studies is that we do not have data with respect to BPD. So still the data is evolving, so we have data only for the short term outcomes. Coming to the safety data, all these RCTs have shown nasal HFO to be safer, but the survey studies have shown whenever you use nasal HFO you have thick secretions, agitation may be more, leaks can be there, abdominal distension like any other non-invasive device. So this is one of the survey studies published 6 years back from the European countries where out of 180 units, just 30 units were using HFOV. So primarily people are using in VLBW babies. The most common indication for using non-invasive HFO is CPAP failure. So the interface they have used is short binasal prongs. I think we'll see in the workstation how does a short binasal prongs look like. Most common pressure they have used is 10 centimeter, frequency of 10 hertz. So people are using in CPAP failure cases. So what's the future research direction would be to evaluate appropriate pressure and the appropriate amplitude as well as interfaces. We need more research on that, and we would also need to evaluate the outcomes on BPD as well as long term. So non-invasive HFO is more like a upcoming device. So this is my last slide. So non-invasive mode is a way forward in managing preterm babies with distress. Non-invasive HFO actually gives advantage of HFOV with gentle ventilation. Nasal HFO can be tried if you have CPAP failure or post-extubation. So we need more evidence in reducing BPD, appropriate pressure, interfaces. So I'll be happy to take any questions. Thank you.
Good afternoon everybody. Hope I am audible. Today I will be talking about humidification and VAP bundles, VAP preventive bundles. I'm Ajay, practicing in a place called Bellary. It's in northern Karnataka, and here I find lots of people coming from Andhra Pradesh and Telangana. And I have to tell you that in Bellary we are very fond of Telugu movies, and so we are in the northern and the Andhra border there. And normal humidification, it's very important. Heat and humidification play a very important role in the newborn, whether for all respiratory support, whether you're giving invasive respiratory support or non-invasive ventilation. And this is required for achieving optimal airway health and functioning during ventilation. And if this is not maintained, physiologically this is not maintained, then the newborns are going to lose the energy as well. Now what is ambient air? So coming to about the humidification, what exactly is ambient air? This ambient air is the air surrounding all of us. It contains, the air is cooler and it contains less water. What about the alveolar air in the lungs? It is contains lots of water vapor, it is fully saturated with water vapor, and it is at the core body temperature, 37 degrees centigrade. So there is a gradient of heat and wave coming from the nose to the alveolus. So the body warms and humidifies the air what we breathe in. So what exactly is humidity? Humidity is the presence of water vapor in the atmosphere or a gas, and can vary with the temperature. And when we refer to the water vapor as such, it is in water vapor molecules are in the gaseous form. The surrounding air is, as we all know, it contains nitrogen, oxygen, carbon dioxide, and water vapor. And we don't see these water vapor molecules, just like the other nitrogen, oxygen, or gas. And this humidity refers to the presence of water vapor in the gas. So how do we measure this humidity? Humidity is measured mainly by two ways: absolute humidity and relative humidity. Absolute humidity refers to an actual amount of water vapor in a volume of gas, and it irrespective of the temperature, and is expressed as milligram per liter. Relative humidity refers to the volume of amount of water vapor in the gas relative to the temperature, and is expressed in percentage form. And one thing we need to know is there is a fixed relation between absolute humidity, relative humidity, and the temperature. So at 37 degree temperature, a gas can hold 45 milligram per liter of water vapor. But the same gas, once it becomes cooler, it can hold just 30 milligram per liter of water vapor. It just gives away the water vapor. So it's not working. So what happens when we breathe in air? So the nose warms, humidifies, and filters the inspired air. The pharynx, trachea, the bronchial tree also warms, humidifies, and filters the inspired air. By the time the inspired air reaches the oropharynx, it has warmed to 34 degrees centigrade, and the gas is nearly 80 to 90% saturated with water vapor. By the time the inspired air reaches the carina, it is warmed to the body temperature of 37 degrees centigrade, and it is 100% saturated. So this gradients, it becomes warm and humidified by the time it reaches the carina. And this particular area in an adult, where it reaches attains the body temperature of 37 degrees and gets in full saturation, is called as isothermic saturation boundary. In adults, it's about 5 centimeters below the carina. So this is the room air, 22 degrees centigrade temperature surrounding us here, and it contains water vapor content of 7 milligram per liter. By the time it reaches the alveoli, it is 37 degree temperature with the 47 milligram per liter content of absolute humidity, and this particular is temperature and the water vapor content is the optimal humidity which is required. This is the optimal humidity. So what happens when we breathe through the mouth? What happens when we start breathing rapidly? What happens if we put in a patient an ET tube without conditioning the gas? So this ISB shifts downwards. This compromises the body heat and moisture exchange mechanism. That's the reason humidity therapy is very much essential here. So airways of newborns and young infants are fundamentally different from adult airways in terms of anatomy and physiology. They're very, very sensitive. The respiratory mucosa is highly sensitive. It can get damaged very, very easily. There are several reasons for delivering a respiratory gases that require special consideration, mainly for this mucociliary transport system. This plays a very, very crucial role in the airway defense mechanisms. And the other reason is we need to warm the gas. What we delivering to the baby is because of the thermal regulation, and is also for an effective ventilation also. So what exactly is this mucociliary transport? It's mainly composed of 3 layers: the cellular layer, aqueous layer, viscoelastic gel layer. All these 3 layers are very sensitive. It can easily get damaged if the temperature and humidity is not maintained. And delivering the suborbital heat and moisture caused progressive slowing and inefficient airway. So when we give invasive ventilation, if this is bypassed, or even during non-invasion, this can get compromised if we are not giving the heat and humidity at the correct levels. So what is thermal regulation? It is a process of allowing the body to maintain core temperature even when the surrounding temperature is different. And an adult at a good thermal control can maintain a body temperature as low as 0 degrees centigrade. But what about the full-term newborn? They can maintain a full good body temperature, maybe up to 20 degrees or 23 degrees. Beyond that, they go in for hypothermia. This hypothermia, we all know, is a significant contributor to morbidity and mortality in newborns. So the invasive ventilation, there are many studies pointing out this. The invasive ventilation with cold and dry gases are shown to cause a decrease in rectal temperature of nearly 1.4 degrees centigrade, and with just 1 hour of ventilation. That's the reason we need to humidify and condition the air what we give in. So what is humidification? Humidification is a method of artificially conditioning the gas used in the respiration of a patient as a therapeutic modality. There are 2 ways of humidification. One is the active method, and there is a passive method. In active method, you give heat and water or both to the device. In a passive method, you recycle the heat and humidity which is exhaled by the patient. What about in the non-invasive ventilation modes, whether it's CPAP or whether it's HFNC, we do give humidification, condition the baby. Is it really required? In these non-invasive normal condition mechanism of inspired gas is not really bypassed as such. But despite this, the gas is routinely preconditioned. When you talk about condition, we are heating and humidifying at the right temperature. The lots of adult data favors conditioning, especially the most important one is the comfort level for an adult. Then there is the adult data suggests there is lots of improvement in the tolerance, improves airway function, it improves the secretion clearance. There is lot of data which proves that heat and humidified gases in a non-invasive ventilation really helps the patients. The neonatal data of condition is not available. Probably what applies to adults applies to the babies as well. So what are the various methods of heating and humidity? One, we have medical gas. We routinely use medical gases. When the medical gases come with a temperature of approximately around 23 or 24 with a humidity of just 2 milligram per liter. This 2% absolute relative humidity, and this has to reach the optimal humidity level. This we need to heat it to 37 degrees, and the water vapor should be at fully saturated with the gas what we deliver. How do we do this? We do this mainly by two methods. One is passive humidification using heat and moisture exchanger, that is HMV, and there is active humidification using the heated humidifier. Usually what we use is a servo heated humidifier. Both act to warm inspired gas and water content. Coming to this passive heat and moisture exchanger, it is also called as artificial nooses. This is designed to recover part of the heat and moisture contained in the expired air of the patient. There is a sponge which absorbs the heat and condenses the water vapor during expiration and subsequently releases during inspiration. Some HMEs are additionally coated with bacterial substances, and they have a filter also, bacterial and viral filter. What are the advantages of HMV? They are very, very simple devices, cheap, they're low risk for contamination, but can we use it in newborns? It creates lots of dead space there. It increases the ventilator requirements, it increases the carbon dioxide levels, it increases artificial airway blockade also. And HMVs during invasive ventilation is not usually used, very rarely used in newborns, very rarely it is used as a newborn transport. And HMVs are not recommended in non-invasive support. The other method is by active heated humidifier. This enables, what happens here is it enables a gas to transport over a heated water reservoir. The respiratory gas is warmed inside the humidification chamber to a set target temperature, and the water vapor is added from the heated water reservoir. And water within the chamber evaporates by adding water vapor into the gas path. And this is usually placed very near to the inspiratory, it is placed in the inspiratory limb very near to the ventilator. And this should deliver to the core body temperature and full saturation, that is optimal humidity, what we need to attain. And we need to be very careful with the under humidification, especially in the inspiratory limb, as the previous speakers were pointing it out. This can create lots of problems. So that can cause rainout, lots of condensation can occur, and to prevent that, there is a heated wire in the inspiratory circuit which can maintain the temperature all through the inspiratory limb. In that way, the inspiratory limb need not get cold even after it passes through the humidifier till reaches the ventilator. Some mist can be seen in the inspiratory limb and the expiratory limb, but in the inspiratory limb there should not be any condensation at all. Dry circuit is a bad sign, it should not be allowed to happen, and the humidifier is usually set at a temperature of 37 degrees, and the gas content of absolute humidity is 44 milligram per deciliter, and this corresponds to the full saturation. And there is this humidifier is recommended in non-invasive support. And what does the evidence say with respect to humidification in various modes of respiratory support? In the newborn resuscitation, though it is not usually used in many units, but many units are taking up humidification, both heat and using humidifiers for resuscitation. and there is emerging research going on, and many units are accepting this, and there are various studies coming out saying that it prevents hypothermia in premature babies who have been resuscitated. And invasive ventilation, so this one is mandated by clinical guidelines, and non-invasive ventilation, the evidence suggests, though it is not mandated in clinical guidelines, but heat and humidification during NIV support by the clinical data plays a very important role, and it is well supported by the literature and recommended in the clinical guidelines. So whether we are giving invasive support or non-invasive, whether we are giving CPAP or HFNC, we need to keep a temperature in the humidifier as 37 degrees centigrade. And during invasive support, when we intubate the baby, we directly give this particular optimal humidity to the baby, 37 degrees, 44 and 100% saturation. But during non-invasive support, though we may be able to deliver this till the nose, but what happens in the oropharynx, the temperature comes down, and various devices give different temperature in the oropharyngeal region. But the essential humidity in non-invasive, what is essential is 37 degrees at least, 32 of absolute humidity, and with 96% saturation of air. What if we don't give humidity, correct humidity or correct temperature to the baby during respiratory support? Low temperature, high humidity, we can cause hypothermia, water condensation. Water condensation can create lots of problems. It can create ventilator to malfunction. It can create increased airway resistance. It can be a nidus for bacterial infection also. High temperature, high humidity, high thermal damage to cells, water condensation, reduced surfactant activity, it can create ventricle-associated pneumonias. Low temperature and low humidity can create hypothermia, fixed secretions, atelectasis, thereby decreasing the lung complaints, reduced surfactant activity. High temperature and low humidity can cause thermal damage, it can cause mucus plugs, it can cause atelectasis and reduce surfactant activity. So the main intent of artificially conditioning respiratory gas is to give heat and humidification to produce as much as possible what normally exists in the respiratory passages. And if we don't give proper heat and humidity to the babies, it can cause severe lung injury as well. And heated humidification is a standard requirement in invasive ventilation as per clinical guideline practice, and it is widely recommended for non-invasive ventilation also. So I'll quickly go through this, another topic what we are supposed to discuss here, ventilator-associated pneumonia, the preventive approach bundle. This what applies to many recommendations what is given here applies to the non-invasive practices also. So ventilator-associated pneumonia, we know, but hospital-acquired pneumonia is a pneumonia that occurs 48 hours or more after admission and did not appear to be incubating at the time of admission. The ventilator-associated pneumonia is a pneumonia occurs more than 48 hours after once we start intubating the baby. It's a very common and serious problems among mechanical ventilated neonates. It is associated with increased morbidity, mortality and prolonged length of hospital stay. It causes a significant economic burden for the health system, and various risk factors for this mainly probably are the duration of mechanical ventilation, low birth weight babies, infants with low gestational age, and possible causes are the sedation, frequent tracheal suctioning, parenteral nutrition, antibiotics, reintubation, BPD or steroid which are being used. The diagnostic criteria for this, the CDC defines VAP, especially this mainly for infants less than 1 year. A mechanical ventilation baby at least 48 hours with a combination of these three criteria: radiological, clinical and lab criteria. The radiological mainly is the new or progressive or persistent infiltrates, consolidation cavity or pneumococcyles, clinical signs and symptoms, worsening of gas exchange, and one of these three at least: temperature instability if the baby goes in for hypothermia, especially in premature newborn babies, WBCs count either more than 15,000 count, or it's sudden onset of wheezing, rales, or there is a bradycardia or a tachycardia with a heart rate of more than 170. The other criteria which are essential is the microbiological findings. At least one of the following are essential: positive blood culture, positive pleural fluid culture, or a positive alveolar fluid aspirate culture. And coming to this VAP bundle, what exactly is bundle approach? It is a set of evidence-based practices that when performed collectively and reliably have shown to improve the patient outcome. And the prevention of ventilator associated pneumonia is a key issue which we need to deal with. And to decrease this rate, a group of interventions called VAP bundle has been used for the last 10 years in adult intensive care units. And it's the same thing, many other newborn units also have started using their own VAP bundles. And this VAP bundle predominantly includes the following: the healthcare professional training. This healthcare professional, the healthcare workers need to be trained in the various strategies, important preventive aspects here. The strict adherence to hand hygiene guidelines, and especially when we wear this sterile gloves. And the sterile airway management is very essential, especially when we are intubating a baby. Of course, we all use the ET tubes, disposable ET tubes, especially we need to be very careful with the laryngoscope. We need to properly disinfect them before we use it. Proper positioning of the head, bed to head ratio, elevation at an angle of 30-40. Some people advocate around 15-degree angle. This is mainly to prevent gastric microaspirations. Intubation, reintubation, and IT suction, as much as possible not to keep on intubating, prevent reintubation. That is very, very important. The change in circuit only if it is visibly soiled or if it is malfunctioning, and periodic draining and discarding of ventilator circuit condensate is very, very essential. And the most important thing is, whenever we are ventilating, invasively ventilating a baby, we need to try and as much as possible to wean off from the invasive mode to a non-invasive mode like nasal CPAP or other modes of non-invasive ventilation. Thank you. Good afternoon, everybody. Hope I am audible. Today I will be talking about humidification and VAP bundles, VAP preventive bundles. I'm Ajay, practicing in a place called Bellary. It's in northern Karnataka, and here I find lots of people coming from Andhra Pradesh and Telangana. And I have to tell you that but in Bellary we are very fond of Telugu movies, and so we are in the northern and the Andhra border there. And normal humidification It's very important. Heat and humidification play a very important role in the newborn, whether for all respiratory support, whether you're giving invasive respiratory support or non-invasive ventilation. And this is required for achieving optimal airway health and functioning during ventilation. And if this is not maintained, physiologically this is not maintained, then the newborns are going to lose the energy as well. Now what is ambient air? So coming to about the humidification, what exactly is ambient air? This ambient air is the air surrounding all of us. It contains, the air is cooler and it contains less water. What about the alveolar air in the lungs? It is contains lots of water vapor, it is fully saturated with water vapor, and it is at the core body temperature, 37 degrees centigrade. So there is a gradient of heat and wave coming from the nose to the alveolus. So the body warms and humidifies the air what we breathe in. So what exactly is humidity? Humidity is the presence of water vapor in the atmosphere or a gas, and can vary with the temperature. And when we refer to the water vapor as such, it is in water vapor molecules are in the gaseous form. The surrounding air is, as we all know, it contains nitrogen, oxygen, carbon dioxide, and water vapor. And we don't see these water vapor molecules, just like the other nitrogen, oxygen, or gas. And this humidity refers to the presence of water vapor in the gas. So how do we measure this humidity? Humidity is measured mainly by two ways: absolute humidity and relative humidity. Absolute humidity refers to an actual amount of water vapor in a volume of gas, and it irrespective of the temperature, and is expressed as milligram per liter. Relative humidity refers to the volume of amount of water vapor in the gas relative to the temperature, and is expressed in percentage form. And one thing we need to know is there is a fixed relation between absolute humidity, relative humidity, and the temperature. So at 37 degree temperature, a gas can hold 45 milligram per liter of water vapor. But the same gas, once it becomes cooler, it can hold just 30 milligram per liter of water vapor. It just gives away the water vapor. So it's not working. So what happens when we breathe in air? So the nose warms, humidifies, and filters the inspired air. The pharynx, trachea, the bronchial tree also warms, humidifies, and filters the inspired air. By the time the inspired air reaches the oropharynx, it has warmed to 34 degrees centigrade, and the gas is nearly 80 to 90% saturated with water vapor. By the time the inspired air reaches the carina, it is warmed to the body temperature of 37 degrees centigrade, and it is 100% saturated. So this gradients, it becomes warm and humidified by the time it reaches the carina. And this particular area in an adult, where it reaches attains the body temperature of 37 degrees and gets in full saturation, is called as isothermic saturation boundary. In adults, it's about 5 centimeters below the carina. So this is the room air, 22 degrees centigrade temperature surrounding us here, and it contains water vapor content of 7 milligram per liter. By the time it reaches the alveoli, it is 37 degree temperature with the 47 milligram per liter content of absolute humidity, and this particular is temperature and the water vapor content is the optimal humidity which is required. This is the optimal humidity. So what happens when we breathe through the mouth? What happens when we start breathing rapidly? what happens if we put in a patient an ET tube without conditioning the gas. So this ISB shifts downwards. This compromises the body heat and moisture exchange mechanism. That's the reason humidity therapy is very much essential here. So airways of newborns and young infants are fundamentally different from adult airways in terms of anatomy and physiology. They're very, very sensitive. The respiratory mucosa is highly sensitive. It can get damaged very, very easily. There are several reasons for delivering a respiratory gases that require special consideration, mainly for this mucociliary transport system. This plays a very, very crucial role in the airway defense mechanisms. And the other reason is we need to warm the gas. What we delivering to the baby is because of the thermal regulation, and is also for an effective ventilation also. So what exactly is this mucociliary transport? It's mainly composed of 3 layers: the cellular layer, aqueous layer, viscoelastic gel layer. All these 3 layers are very sensitive. It can easily get damaged if the temperature and humidity is not maintained. And delivering the suborbital heat and moisture caused progressive slowing and inefficient airway. So when we give invasive ventilation, if this is bypassed, or even during non-invasion, this can get compromised if we are not giving the heat and humidity at the correct levels. So what is thermal regulation? It is a process of allowing the body to maintain core temperature even when the surrounding temperature is different. And an adult at a good thermal control can maintain a body temperature as low as 0 degrees centigrade. But what about the full-term newborn? They can maintain a full good body temperature, maybe up to 20 degrees or 23 degrees. Beyond that, they go in for hypothermia. This hypothermia, we all know, is a significant contributor to morbidity and mortality in newborns. So the invasive ventilation, there are many studies pointing out this. The invasive ventilation with cold and dry gases are shown to cause a decrease in rectal temperature of nearly 1.4 degrees centigrade, and with just 1 hour of ventilation. That's the reason we need to humidify and condition the air what we give in. So what is humidification? Humidification is a method of artificially conditioning the gas used in the respiration of a patient as a therapeutic modality. There are 2 ways of humidification. One is the active method, and there is a passive method. In active method, you give heat and water or both to the device. In the passive method, you recycle the heat and humidity which is exhaled by the patient. What about in the non-invasive ventilation modes, whether it's CPAP or whether it's HFNC, we do give humidification, condition the baby. Is it really required? In these non-invasive normal condition mechanism of inspired gas is not really bypassed as such. But despite this, the gas is routinely preconditioned. When you talk about condition, we are heating and humidifying at the right temperature. The lots of adult data favors conditioning, especially the most important one is the comfort level for an adult. Then there is the adult data suggests there is lots of improvement in the tolerance, improves airway function, it improves the secretion clearance. There is a lot of data which proves that heat and humidified gases in a non-invasive ventilation really helps the patients. The neonatal data of condition is not available. Probably what applies to adults applies to the babies as well. So what are the various methods of heating and humidity? One, we have medical gas. We routinely use medical gases. When the medical gases come with a temperature of approximately around 23 or 24 with a humidity of just 2 milligram per liter. This 2% absolute relative humidity. and this has to reach an optimal humidity level. This we need to heat it to 37 degrees, and the water vapor should be at fully saturated with the gas what we deliver. How do we do this? We do this mainly by two methods. One is passive humidification using heat and moisture exchanger, that is HMV, and there is active humidification using the heated humidifier. Usually what we use is a servo heated humidifier. Both act to warm inspired gas and water content. Coming to this passive heat and moisture exchanger, it is also called as artificial nozzles. This is designed to recover part of the heat and moisture content in the expired air of the patient. There is a sponge which absorbs the heat and condenses the water vapor during expiration and subsequently releases during inspiration. Some HMEs are additionally coated with bacterial substances, and they have a filter also, bacterial and viral filter. What are the advantages of HMV? They are very, very simple devices, cheap, they're low risk for contamination, but can we use it in newborns? It creates lots of dead space there. It increases the ventilator requirements, it increases the carbon dioxide levels, it increases artificial airway blockade also. And HMVs during invasive ventilation is not usually used, very rarely used in newborns, very rarely it is used as a newborn transport. And HMVs are not recommended in non-invasive support. The other method is by active heated humidifier. This enables, what happens here is it enables a gas to transport over a heated water reservoir. The respiratory gas is warmed inside the humidification chamber to a set target temperature, and the water vapor is added from the heated water reservoir. And water within the chamber evaporates by adding water vapor into the gas path. And this is usually placed very near to the inspiratory, it is placed in the inspiratory limb very near to the ventilator. And this should deliver to the core body temperature and full saturation, that is optimal humidity, what we need to attain. And we need to be very careful with the under humidification, especially in the inspiratory limb, as the previous speakers were pointing it out. This can create lots of problems. So that can cause rainout, lots of condensation can occur, and to prevent that, there is a heated wire in the inspiratory circuit which can maintain the temperature all through the inspiratory limb. In that way, the inspiratory limb need not get cold even after it passes through the humidifier till reaches the ventilator. Some mist can be seen in the inspiratory limb and the expiratory limb, but in the inspiratory limb there should not be any condensation at all. Dry circuit is a bad sign, it should not be allowed to happen, and the humidifier is usually set at a temperature of 37 degrees, and the gas content of absolute humidity is 44 milligram per deciliter, and this corresponds to the full saturation. And there is this humidifier is recommended in non-invasive support. And what does the evidence say with respect to humidification in various modes of respiratory support? In the newborn resuscitation, though it is not usually used in many units, but many units are taking up humidification, both heat and using humidifiers for resuscitation, and there is emerging research going on, and many units are accepting this, and there are various studies coming out saying that it prevents hypothermia in premature babies who have been resuscitated. And invasive ventilation, so this one is mandated by clinical guidelines, and non-invasive ventilation, the evidence suggests, though it is not mandated in clinical guidelines, but heat and humidification during NIV support by the clinical data plays a very important role, and it is well supported by the literature and recommended in the clinical guidelines. So whether we are giving invasive support or non-invasive, whether we are giving CPAP or HFNC, we need to keep a temperature in the humidifier as 37 degrees centigrade. And during invasive support, this, when we intubate the baby, we directly give this particular optimal humidity to the baby, 37 degrees, 44 and 100% saturation. But during non-invasive support, though we may be able to deliver this till the nose, but what happens in the oropharynx, the temperature comes down and various devices give different temperature in the oropharyngeal region. But the essential humidity in non-invasive, what is essential is 37 degrees at least, 32 of absolute humidity, and with 96% saturation of air. What if we don't give humidity, correct humidity or correct temperature to the baby during respiratory support? Low temperature, high humidity, we can cause hypothermia, water condensation. Water condensation can create lots of problems. It can create ventilator to malfunction. It can create increased airway resistance. It can be a nidus for bacterial infection also. High temperature, high humidity, high thermal damage to cells, water condensation, reduced surfactant activity, it can create ventricle-associated pneumonias. Low temperature and low humidity can create hypothermia, thick secretions, atelectasis, thereby decreasing the lung complaints, reduced surfactant activity. High temperature and low humidity can cause thermal damage. It can cause mucus plugs, it can cause atelectasis and reduce surfactant activity. So the main intent of artificially conditioning respiratory gas is to give heat and humidification to produce as much as possible what normally exists in the respiratory passages. And if we don't give proper heat and humidity to the babies, it can cause severe lung injury as well. And heated humidification is a standard requirement in invasive ventilation as per clinical guideline practice, and it is widely recommended for non-invasive ventilation also. So I'll quickly go through this another topic what we are supposed to discuss here. Ventilator-associated pneumonia, the preventive approach bundle. This what applies to many recommendations what is given here applies to the non-invasive practices also. So ventilator-associated pneumonia, we know, but hospital-acquired pneumonia is a pneumonia that occurs 48 hours or more after admission and did not appear to be incubating at the time of admission. The ventilator-associated pneumonia ventilator-associated pneumonia is a pneumonia occurs more than 48 hours after once we start intubating the baby. It's a very common and serious problems among mechanical ventilated neonates. It is associated with increased morbidity, mortality and prolonged length of hospital stay. It causes a significant economic burden for the health system, and various risk factors for this mainly probably are the duration of mechanical ventilation, low birth weight babies, infants with low gestational age, and possible causes are the sedation, frequent tracheal suctioning, parenteral nutrition, antibiotics, reintubation, BPD or steroid which are being used. The diagnostic criteria for this, the CDC defines VAP, especially this mainly for infants less than 1 year. A mechanical ventilation baby at least 48 hours. with a combination of these three criteria: radiological, clinical, and lab criteria. The radiological mainly is the new or progressive or persistent infiltrates, consolidation cavity or pneumococcyls, clinical signs and symptoms, worsening of gas exchange, and one of these three at least: temperature instability if the baby goes in for hypothermia, especially in premature newborn babies, WBCs count either more than 15,000 count, or it's sudden onset of wheezing, rales, or there is a bradycardia or a tachycardia with a heart rate of more than 170. The other criteria which are essential is the microbiological findings. At least one of the following are essential: positive blood culture, positive pleural fluid culture, or a positive alveolar fluid aspirate culture. And coming to this WAP bundle, what exactly is bundle approach? It is a set of evidence-based practices that when performed collectively and reliably have shown to improve the patient outcome. And the prevention of ventilator associated pneumonia is a key issue which we need to deal with. And to decrease this rate, a group of interventions called WAP bundle has been used for the last 10 years in adult intensive care units. And it's the same thing, many other newborn units also have started using their own WAP bundles. And this WAP bundle predominantly includes the following: the healthcare professional training. This healthcare professional, the healthcare workers need to be trained in the various strategies, important preventive aspects here. The strict adherence to hand hygiene guidelines, and especially when we wear this sterile gloves. And the sterile airway management is very essential, especially when we are intubating a baby. Of course, we all use the ET tubes, disposable ET tubes, especially we need to be very careful with the laryngoscope. We need to properly disinfect them before we use it. Proper positioning of the head, bed to head ratio, elevation at an angle of 30-40. Some people advocate around 15-degree angle. This is mainly to prevent gastric microaspirations. Intubation, reintubation, and ET suction, as much as possible not to keep on intubating, prevent reintubation. That is very, very important. The change in circuit only if it is visibly soiled or if it is malfunctioning. And periodic draining and discarding of ventilator circuit condensate is very, very essential. And the most important thing is, whenever we are ventilating, invasively ventilating a baby, we need to try and as much as possible to wean off from the invasive mode to a non-invasive mode like nasal CPAP or other modes of non-invasive ventilation. Thank you.
Any other slides? I think it's post-lunch session, so I'm not going to talk much and not take much time, because the more I talk, the more we sleep here. So quickly, I'll complete it within a short span of about 5 to 10 minutes, and then we will do practically more on the workstations, how to do about. All my speakers, eminent speakers, have already covered most of the nursing care, what needs to be done. In few of their slides, it has been overlapped, so I'm not going to take much time on discussing of all those. So for me or for anybody here, the success of non-invasive ventilation predominantly, or even for that matter invasive ventilation, depends on an optimal nursing care, because that's the operational fulcrum on which an unit runs. It is not only in terms of quality but also on the quantity. If you are giving them 1:5, 6 babies, then the quality would obviously deteriorate, especially in non-invasive ventilation, where the chance of injuries, if the interfaces are not appropriately placed, are much more. So why do we need this topic of nursing care? You can clearly see, and my previous speakers have already spoken about, is the importance of nursing care, which can lead to these devastating complications. Although they look
very trivial for you, but for parents and for the babies, this is for a lifetime injury. If you are going to do the last one, the destruction of the nasal septum, it's going to have a long lasting effect on the babies. So we need more nursing care, and how optimal we can do, we'll discuss here, and more so in the workstations. And we have been taught from our MBBS days is first, our first job is to do no harm, that is primum non nocere. No sick baby should be harmed. Then you treat it. First you should not do any harm to that babies. So when I was going through what constitutes optimal nursing care, there could be handling the babies, positioning the babies, then I thought predominantly these are the few factors which determine the quality of a nursing care of a unit and the outcome of the babies. So for me, hand hygiene, it tops the list for any care for that matter. I am not going to discuss much on that nonetheless. Selection of appropriate size and mask, this is the most important factor for a success of NIV. Again, the more leaks, or if you do an undersized mask or prongs, that again leads to inadequate supply of pressures or excess supply of pressures. Proper securing and fixing of the nasal interfaces. Monitor and scoring of nasal injuries, how we are going to score these nasal injuries, how often we need to score that. We will just take a quick glance on that. Heating and humidification, my previous speaker has already spoken about it, so I am not going to overlap that again. Ongoing assessments, which is pain, if we need to assess whether the baby is having pain, whether it needs sedation or not in non-invasive ventilation. Suctioning, how often we need to do, how we need to do, quick glance on that as well, and routine care, like blood gases, clinical examination and stuffs. Physiotherapy and positioning, how important, and last but not the least, which is in the current era we should not miss any baby for that matter, nutrition and early nutrition and developmental supportive care. Interfaces, this again we are going to speak much more in the workstations, like how to select an appropriate interfaces. As we have already seen in the previous slides, our previous speakers have spoken what kind of interfaces we already have. It could be masks, Hudson prongs, you can use the short binasal prongs as well, or HFNC, Ram's cannula or simple nasal cannula, whatever kind of interfaces, how we need to choose them. Variable sizes depends on the diameter, so we need to choose based on the prototype which we have, and the based on the companies. Bonnet or the head bonnet based on the head circumference. Headgear and chin straps rarely used. Of course, we need to use it whenever it's required. Sorry. Again, this has been shown in the previous slides. What is an optimal nasal cannula, the size of HFNC. The first two is which matters to us, which we are again going to see in the workstations. Ram's cannula, it's again color coded based on the color codings. If we have in one of the workstations, I'll be able to happy to show it to everyone, is select based on the size as well, because if you use inappropriate size, it again leads to leakage or inappropriate fitting, which leads to failure of NIV. This is color coded based on the weight of the babies, whether it's more than 2.5 kilos, 1 to 2.5, less than 1 and less than 750 grams. And how to secure this interface is again a practical question which will be discussed in the workstation. So these are the three predominantly used methodologies in fixing this. However, there are customized, some of the units used a customized way of securing the interfaces. This is the tegadum or diodum, which we put it on that, and the second one is a cannulate type, which you can see most of the units use that. We often use the first one. Second one, in some cases, if you are using prongs, especially the short binasal prongs, the mid one is most useful, and the last one is you can also use the velcro types. These are the three most commonly used methodologies to secure the interfaces. However, you can customize provided the baby is comfortable in that. That's very important, is comfort of the baby and its efficacy of the NIV which we are using. HFNC, again in CPAP we don't want a leak. In HFNC we want some amount of leak there, considering that the pressure generated can vary anywhere from 2 to 9 or even more if the mouth is closed, because you are giving a high flow there. That's the reason this is the first one is the correct one, and the second one, because it's very tightly fitted, it's incorrect one. Scoring for nasal injury, recording for nasal injury in each shift is a must. All the nurses have to be trained and they have to be shown the importance of how to score them, what scoring chart your unit uses. Any documented injury, if your scores tells okay there is some injury which is just starting now, take it serious, because it is going to become worse and worse if you neglect it. So even if it is a blanching, take it serious. Okay, this has started, we need to do either a rotation policy, we need to change the interface, or we will move on to something much more comfortable, which is HFNC for a brief amount of time, So cycling also helps. Use barrier dressing, which we have spoken about, Tegaderm, silicone plaster, Deodum, or a Velcro, that's a long term CPAP or NIV, rotation of mask with prongs. Some of the speaker has also mentioned about the importance of rotation if it is required for long term. This is a validated tool which if some of the units are using this, it will be helpful for the nurses if they do this in each shift and see whether there is a beginning of injury, or if it is an injury whether it is getting better if you are doing a rotation policy of mask and prongs. There are 4 components which are scored. One is tip of the nose, one is the nasal septum, third is the nostrils, and fourth is the nose shape. You can see, and it is already published very long back. Based on the scorings, we say 0 no injury, 1 to 4 is mild injury, 5 to 6 moderate injury, and more than 7 severe injury, and in workstation we will discuss what to do with these injuries. This is the other scoring methodologies. It is simple, which is stage 1, 2 and 3. It is again used in a few of the trials, how to score based on the type of nasal injury. The first one is, you can see just the erythema which has started. So that is the starting point. So we need to pick up those and then try to intervene at that point of time. The second one, you can see there is an ulceration which has started, and that leads to the deep tissue injury, which is the final stage, and that will lead to long lasting impact on these babies. HFNC less traumatic than CPAP, which one of the speakers have eminent speakers have already shown in details of what is the importance of HFNC. Barrier dressing causes less nasal injury than no barrier dressing, that is use of Tegaderm, Deodum, or a Velcro type. Nasal mask, perhaps not very convincing evidence. However, most of us feel here, if you have used CPAP and by mask or prongs, you feel that masks are little superior than prongs in terms of clinical efficacy. However, statistically you may not show that. This is the HFNC less traumatic than CPAP, which we all know based on many studies. Barrier dressing causes less nasal injury than no barrier dressing. Again, a few studies though, but the statistical significance is very significant, and nasal mask more than short binasal prongs. This is a monitoring chart, again shown again and again in these talks, previous talks. You need to know this. Heating and humidification. Just adding to the points which is which the previous speaker has spoken. When the alarm is bleeping, make sure that you don't wait for it, just make sure that it is being filled immediately. That means the humidification and heating is done adequately, and we are not making the alarm bleep for long, because no condensation in the inspiratory limb and some in the expiratory limb. That is also the predominantly most of the babies will be jittery on the CPAP or something, because there is no adequate humidification or no heating. If we are giving them more cold air, dry air, they are going to be more agitated on CPAP, and if the humidification is not up to the mark, they are going to be more agitated. And some of the reasons for failing a CPAP, or if you tell the baby is not comfortable on CPAP, is perhaps one of these reasons. Pain scoring, you can use any of the pain scoring if you feel the baby is not comfortable. However, routine use of sedation in non-invasive ventilation is not required, or there is no evidence as such. Even in invasive ventilation, there is no routine use of sedation is not recommended. Use of non-pharmacological methods, like pharmacological methods of pain relief in neonatal care is kangaroo mother care. Then use of EBM, you can use, sucrose not available in India as far, I have not used in here. However, then what else? Swaddling, the first diagram is just swaddling them, also relieves gives lot of comfort to these babies. And clustered care, reducing the pricks, making them clustered, and then doing the procedures. All these adds to the decrease or reduction of agitation in these babies getting non-invasive ventilation. Again, routine suction is not just you just have to insert the catheters too long. It's a non-invasive pharyngeal suction where patency of the upper airway, as we know, is very important for the success of non-invasive ventilation. Airway secretions can cause obstruction during or after NIV. So intermittent suction by catheter in nose, when you put the catheter inappropriately without saline, and if the mucosa is dry already, it can cause bleeding, and that again leads to vicious cycle of baby getting agitated, then again doing suction causing nasal trauma to the nasal mucosa, bleeding causing blockage. You are doing a vicious cycle, and then again leads to failure of NIV. So it's not moving. Yeah, positioning, what position is better in NIV? There is no clear-cut evidence-based position. However, any position which comforts the infant and maintain airway. Although prone position have shown to increase the oxygenation in ventilated babies, this is not going to improve outcomes. Clear-cut evidence is not there which improves the outcomes. They are going to improve the oxygenation briefly even in ventilated babies. So prone is ideally better. If your saturations are not improving, you can try that, but any position, it could be supine or prone, which comforts the baby in a non-invasive ventilation, is going to help. Physiotherapy is not routinely indicated, again is very dangerous to do in extreme premature babies if you are handling 23-24 weeker babies. So routinely not indicated, and there is no evidence too for that. So should be gentle and use the indications if you think, if you have put a tube down very low and there is a collapse of right upper lobe, which we often see. If it's due to an infection, viral infection, which is causing collapse consolidation, to relieve that post extubation where you see some amount of consolidations and there's significant secretions which is thick, copious. Make sure that you avoid babies unnecessarily who are very small because of risk of IVH, or in a baby who has pulmonary hemorrhage, you try to avoid this. Who are very small, you try to avoid this, and babies who are hemodynamically unstable. Nutrition and DAC, early introduction of tube feeds in these babies is also a prime important in a baby who is getting non-invasive. So if we focus on more on non-invasive ventilation and forget the important things which is of early introduction of tube feeds, which is minimal enteral nutrition. That's also a very important nursing care which need not be forgotten. Can give full feeds if tolerated. Again, there is no contraindication as such. We all know babies who are on non-invasive ventilation can get full tube feeds. Developmental supportive care, although not related to topic, but I thought it's very important to know that it's a part of nursing care. When you are giving ventilation or non-invasive ventilation, that's predominantly what we focus on: minimal handling, cue-based care, KMC, and postural support or positioning. It could be making a nest, swaddling these babies. That minimal things add to the success of overall care what you are giving. Last, these are the general supportive care, like insertion of an NG tube or OG tube, which we should never forget if the baby is on non-invasive ventilation, like CPAP, HFNC. Aspiration as on when required. Use of pacifiers can be used provided you maintain the asepsis. Chin straps, we'll see what is the importance of chin straps in the workstation. Clinical monitoring, like various RD scoring systems, which we have already read in the previous sessions, and escalation to the duty doctors in case of worsening. Last but not the least, which is forgotten if the unit is busy, is proper documentation by a nurse or by duty doctors. Of if I am on call, I need to document something, whatever I am doing, which is nursing. Documentation helps in a good clinical communication. These things are really very important. Whatever you do has to be documented so that it gets communicated even for auditing purpose. It helps to improve your care. So if you do very good care and if you don't document, that won't get carried forward in future and you don't know how to improve on, correct? So good documentation helps in a good clinical communication. It helps to improve the care based on the effect of the auditor's interventions. It could be electronic or written, doesn't matter. Whatever systems you are using, make sure it's documented whatever you do, structured and concise. Monitoring chart has to be filled appropriately on each shifts. We make sure the nurses do, and which also has medical legal importance. So I think that forms all the components of a proper nursing care. With the previous speakers have shown how to monitor things, how to maintain heating, humidifications and stuff. So I think that's it. Thank you. I'll end my slide with this great saying. Thank you one and all. Any questions, I'm happy to answer. Thank you.
6. We have 5 to 6 workstations now.
Camera power ಬೇಕಾ ಸ್ವಲ್ಪ ಆಮೇಲೆ ಆಫ್ ಮಾಡೋಣ
ಬ್ಯಾಟ್ರಿ ಕ್ಯಾಮ್ರಾ ಆಫ್ ಆಗುತ್ತೆ.
So in my unit, Venkat, ये काम नहीं करा कुछ बोलो. ठीक है. In my unit, we normally used to have a gathering of 40 units, 40 NICU. I have a largest unit in Eastern India. So almost tertiary level, we have ECMO, nitric oxide, everything is there. So when the people will be like on the last minute, no, they will send to us. So we have not luxury of getting this 28-weeker up there. I am the boss. We are the second boss or third boss. When the people has gone to different level, they will come to us. So almost all will get this type of baby on BPD most of the time. The 28-weeker will not get the luxury of giving antenatal steroids. So they have a complicated RDS, and they might be requiring a high FiO2, high PEEP on initial setup. Might have ventilated also. Then rest amount will be like a history for us. But you are treating and dealing a baby who is on CPAP for long time, for many days, 20 days, 30 days like that. So for that type of baby, what will do? CPAP is good, ideal, is fine. PEEP is generating good. But I told at the point of time you have to decide when the nasal injury is getting out. It's not a staging. It's just a gradual process. First they will see some nasal injury will be on the light of redness will be there. Then at that time we will manipulating, okay, prong versus mask. Initial part what will think, mask will give 12 hours, then prong by 12 hours, then we'll change, okay, another 12 hours prong is there. Then what to do, blow away, and the CPAP PEEP will get down. So your purpose is to give a distending pressure for a continuous time, but you are not able to achieve. So at that time what will happen? Just going on manipulating here and there. Just blow away oxygen, food box oxygen, mask, prong, these many things are there along with that. No other option is there. So at that point of time we thought, okay, what will put HFNC. And then now the evidence is so high by putting HFNC that you are equal efficacy to a CPAP when the baby is on improving trend. I am not telling you less than 28-weeker you try on giving a HFNC. Even a primary mode people has shown that is good efficacy. But for a sake of your initial point, when you will be master of that after 2 or 3 years, I am sure that we will start HFNC first as a primary mode. But for the time being, for the next 6 months or something in your unit, try on HFNC as a secondary mode. On CPAP, when you are 2 or 3 days baby on CPAP, and you are getting some problem in CPAP fixing, not delivering properly, or baby on dependent CPAP, you are unable to get down by 30% FiO2, PEEP of 5 or 6, you are fluctuating on that. Just trying on HFNC, switching up to HFNC, and that will be easily convertible. The patient will not get extra money because the circuit will be same. If you putting air bow, the same thing will be there here also. So he's a very simple thing. Will be also bubble chamber will be there, but is a flow driven. If you get into oxygen, the FI2 you can set here, the 30%, 25% flow you can set here, 4 liters, 5 liters, 6 liters like that. And this is a humidifier chamber, and you will get connected to here. So there will be adapter. I think adapter is there, no? That adapter you just put. Yeah. So if you put that one, it will fix it out. And it will be very easy. And the patient will be like almost not completely like out of the NICU, but he will feel he is on the mother side. So yesterday also 126 weeker baby, we put into that after 24 to 48 hours. He's just after giving a CPAP, surfactant, insure, then we'll put back to HFNC. Because we know that this baby is going to be a long time for us. Yeah.
I'm using for last 5 years.
Yeah. So that's good. Means if who is using now, they will be more tending towards HFNC, not towards the CPAP. Because it's very friendly usually. And mother, nowadays all mothers are coming and asking you, can I hold my baby? Okay, so at that time you cannot discourage them, like okay, no, baby on CPAP or something you have to try after 15 days, because they want to come, they want to do something. So you have to encourage them by the side of the machine. So put on KMC, put on HFNC with KMC. That will be ideal scenario. So what are the things we will have to monitor? That appropriate size, what I told in the morning, the size should be not snugly fit. In a CPAP and HFNC, the difference between this one is the size of the prong. In CPAP what will happen? This will be completely fit. There should not be any space. If space is there, there is loss of PEEP. But here you are allowing at least 30% leaks has to be there. So it will fit into 50% to 80%, not beyond that. Because you are allowing the PEEP or that flow to be go out, so that the CO2 what is there, it should come out. The CO2 has to go out by the leak of that HFNC prong. So at least 80% or 70%. If you like to tell also same thing, like 50 to 60% you put on nair size. So there should be a color code. Everybody know that okay, this is color code. It's also written here. This red, is inside is red. This will be the green. The size also be written here. Which one will be the preemie, which will be neonates, which will be infant, and what is the liter, maximum liter, it will give it out. You cannot give in like in a preemie baby, like in a red color. You cannot give maximum flow will be up to 10 liters, not more than that. If it's this one a preemie baby, small baby, you just go on to 6 to 8 liters. Beyond 6 to 8 liters, it will not deliver because the flow will be very high for this baby. It will cause more on trauma, barotrauma will be there. So the appropriate size will be there, and you can see this one. This adhesive things is there, so it will fix into it, and never it will cause injury because there is a adhesive type of things. So you can tear it out and take it out. If some 4-5 days again you are just putting the baby somewhere else, or try to getting some like stopping HFNC, then again retrying that HFNC again the adhesive will remain for at least 2-3 times uses. So this adhesive never go on like 1 or 2 days. So adhesive has to be there for a long time. It's biocompatible because this is a one type of like this gum type of things. So it will be like remain on this side. It will never cause the pressure. The pressure effect we are seeing like a bonnet pressure, the fixing pressure, because the pressure you are getting some injury. Never it will cause, because here the pressure is nullified by putting this adhesive. Okay, and the bonnet type of issue is not there. Heavy, you can see.
Movement of the baby also it doesn't.
It will not cause anything. If it will fix like this is going on like this. Okay, only thing the things you have to know that okay, something like the baby positioning. If you are getting the position will be not be good enough, it will also not go on because it will from here it will come out. That glottis has to be open partially. That's the first and foremost thing. The baby position should be good enough. Even a mother is doing KMC also, he has to be seeing that okay, is partially flexed, partially extended, so that it will be good enough. And another thing is there, once is size and the nair size. If you are not seen like okay, you made a chart, put into NICU corner, because sisters are very friendly on that one. If you tell one sister like okay, this is the things I want, they definitely do, because of color coded, they will open it out. If you are getting a 28-weeker baby, prior to that you can see that okay, this prong size is there, and I am opening that appropriate prong. For a 1 kilo baby, this prong is there, and this prong and FI2 and flow liters has to be adjusted accordingly. So 4 to 6 liter for a 1 kilo baby, FI2 at least 30% to 40%, humidifier has to be on, and you will get this one. And this airflow part, you can see, is there any proximal connector is there? The temperature. In other machine, this is a proximal temperature probe. Is giving a feedback. 39 degree is getting 37 degree. Normally 2 degrees Celsius will be there a difference. But here it is not there. In this machine, what is getting it already inbuilt. The sensor is here. This one the sensor. This is the temperature sensor. And he will tell it out 39 I want to be here, and the machine will give automatically. The inbuilt sensor is here, like not like this one. So the sensor is here proximally, and because of that you are getting so much of condensation. The temperature is not fit properly. It might be here, it will not get. If something is getting hot or cold from because of the external temperature, if you put on warmer inside the warmer, it will get externally heat from outside. So the fallacy is this one. To nullify this one made this one. The internal build, the sensor is there. So if a sensor is there, so the sensor is doing all the things. The humidification is part, he will take care. Only
FiO2 is set by this machine.
FiO2 you have to check.
And flow is
Here depend on the oxygen flow you have to set. This oxygen, how much will give, it will go on increasing. 2 liters, it will give on 30%. 4 liters, it will give 40% like that.
Okay,
So only
whenever the FiO2, the flow is to be increased from the main center.
main oxygen, like this connector, it will be here. You can connect this one, no? This one side is there. Yeah, it's a flow driven. So flow, if you are giving extra, it will give on 30%.
Regulated by that
The flow meter.
flow meter.
Flow meter.
Yeah.
So once the flow meter will be set, you are just increasing how much desired FiO2 you want, it will show, display it out.
Okay.
Only you, how much flow you will give, it depends upon you have to set the flow here.
Flow is set from here.
No, the flow is here. Here see.
Flow is here.
The flow up and down, you can see flow. 6 liters, 7 liters, we can set.
Okay.
But oxygen, how much you want,
FiO2.
is depend upon FiO2 is depend upon this flow. Different flow is there. Yeah. So 2 liter oxygen, if a flow is there, it will also show here. Yes, you can see here. This will be see. This is the oxygen. This knob is there.
Why it is,
So-
this is for humid? Okay.
This is water. I think you connect it here, then so that they can know their flow. This connector you get like data. Okay. So you see this.
This is the machine, no?
This is the machine.
This is the
This is
center
the
line flow meter.
oxygen flow
Okay,
meter.
directly from the center
From
line flow
here,
is connected.
you just connect here. If you increase or decrease, depend upon the FiO2 will
This has
decrease.
inbuilt blender in it.
Yeah, inbuilt filter. Because this is oxygen is there and the
This is an inbuilt blender.
air is not there.
With humidifier.
Yeah.
You are not using compressor separately.
Yeah, compressor is not there. So this is good enough. In case of this one, this is a blender is there. So no blender is required for this one.
No blender and compressor both are not required.
Yeah, it's a complete inbuilt compressor. Inbuilt blender is there. Power backup is not this. Completely humidifier depend on
No, no,
this
no,
one.
not about talking about the machine because it has no power.
No power backup is there. Even all machine are like humidifier all are.
Yeah, yeah. तो UPS only there. हाँ नहीं, UPS से ही वो central UPS से ही connect हो.
Yeah. So this will be color coded. All will be color coded. So no need to be mug up like okay how much I'll size will check it out. So then other things is the cap also not required for the baby. If you hold this one, this will be like good enough. The cap is for other things is very fixed for CPAP. For a baby, the cap, all bonnet will come with appropriate things. There will be one connector for bonnet. But here no cap is there inside. You will see when you are opening a CPAP, the bonnet will be there, the cap will be there, all things will be together will be there. But for this is not there. So this will be always user friendly for the patient, for a baby who is taken care by NICU sisters and doctors. Which one, sir? हाँ.
The flow of oxygen does not depend on this ऑक्सीजन की फ्लो खाली FiO2 के लिए करना है।
ओके ठीक है
इस फ्लो से कोई लेना देना उसका नहीं।
इसका flow you are just giving how much flow I told the
Okay.
flow how much PEEP you want so 4 to 6 liter means you have to set 4 to 6 liter. This oxygen the blender is there because inside so you have to check it out okay how much oxygen I am giving the inbuilt blender is there. So the contraindication other things are on acutely exactly for the same for CPAP and HFNC because primary mode is a CPAP the inferiority is there no superiority is there. So if you are trying on HFNC try on a bigger baby. So most of the time even in all the units 80% baby are almost 28 to 34 weeks. Only how many PME baby will get 28 week or less. So that will be on 10% or 5%. So try on all the other baby 22 week or more than that try on HFNC. Okay. So where the silver
term TTN and other things
yeah
are there.
TTN pneumonia even in meconium aspiration yeah
Respiratory
distress even Downey score more than 3 or Silverman more than 3 try on HFNC. This is the dictum nowadays and you will see like so many baby will be getting out of this one. हाँ HFNC
नहीं तो CPAP भी क्यों लगाना सर CPAP में
इसीलिए वही तो प्रॉब्लम है कि अगर किसी को लगा रहे तो
लगाते थे अब तो
हाँ हाँ and if you want to get that exact PEEP you just go and play with your flow the PEEP of 6 or 8 you deliver 4 to 5 PEEP so that much PEEP we are giving on CPAP that will be given on HFNC that purpose is solved it out so that's good because most of the time HFNC are because the derived things people has measured so no need to measure for by us so even a CPAP or PEEP even a PEEP also CPAP sir then also measuring that what Phoenix machine will just display there the PEEP what you are getting the machine that is from measured from here nobody is measuring from the like at the bifurcation of the trachea that exactly PEEP we want we don't want a PEEP of here so previously people used to put a chin strap so that air leak will not be there PEEP how much you are giving that desired PEEP will get so now that is obsolete so you want almost a trachean so even people have seen many studies they have gone through the like a capsule grass bay capsule they put on nasopharyngeal PEEP so how much PEEP they have delivered and they are putting onto that if you are giving this much of depth that much PEEP will deliver through the alveoli that's all and this derived value what is getting in the machine or displaying that is not actually exactly what is getting this is a derived value so all the things is derived. ABG monitoring all the things I think everybody has told so no need to go on that one. ABG depend upon the baby condition baby is improving why to record a ABG if a baby is deteriorating I want to change something do ABG to see okay what is the pH what is the CO2 PO2 the displaying by FiO2 or SPO2 so no need of going on that one and other one is that clinical monitoring that should be there and one chart has to be there what chart even if you can go on to the app you can download this one the what monitoring and sister has to monitor because doctors are always busy and one unit somebody is running a one unit one doctor will be there even a resident also same when there will be 4 or 5 resident one will be busy on putting a central line by putting HFNC they will forget to see okay what is happening to the HFNC so always somebody has to monitor I put HFNC what is the clinical monitoring I am doing and most of the time what will happen we never escalate what we put that will go on to happen either 1 hour or 2 hours and we might have forgotten also we put on something HFNC or CPAP. So at the point of time everybody has to know I put some intervention I have done a larger intervention for a baby who is required a CPAP or HFNC I want a results at the same point of time so every 15 minutes what is happening to the baby are the PEEP is altered are the baby condition deteriorated are the pneumothorax happened how can I know so I want a results every 15 minutes I am checking okay this Downey scoring or Silverman score is 6 now it came to 4 so baby is improving my saturation has gone up to 95 or more than that because once we put an intervention the result has to be shown within 5 or 10 minutes or 15 minutes if I am not getting then I am in trouble even if I can wait up to half an hour or I have to change I am just getting reading all other things CPAP or NIPPV or surfactant what is the baby required in the meantime also you will get a x-ray on your hand so what is happened how severity is there how much that x-ray expansion is there all the things will be there. So in RDS most of the time we are committing towards the RDS now nobody is getting a like okay some meconium aspiration birth asphyxia most of the time all unit having like oh that is out because of good nursing care and the maternity care. Surfactant even put on HFNC also we can give surfactant sir if you are gone beyond 40% FiO2 This one 40% need of surfactant has gone down. By putting a CPAP, is gone to 60% of your surfactant. Less than 22 weeks. I am not talking about more than 22 weeks. So less than 22 weeks. Nobody is talking about surfactant for a 30 weeker or 31 weeker. We never heard, or in now last 2 or 3 years, we have seen like bad RDS who is coming outside if you are not given a delivery room CPAP. So this type of baby, you might be somebody tried on giving oxygen. At initial part they missed it out. By 1 hour or 2 hours they are failing. Then we will end up in giving a surfactant. But not who is baby on delivery room CPAP they are given.
Suppose that the child is on HFNC.
Yeah.
But he is showing signs of pulmonary hemorrhage.
Pulmonary hemorrhage will occur on the later part. Nobody has got within 24 hours or 48 hours pulmonary hemorrhage. Ideally speaking, this pulmonary hemorrhage, nobody has seen what exact pathology.
Second or third?
Yeah, if his coagulopathy is there, or surfactant inadvertently given extra surfactant, or might be PDA got up and down. This is the clinical scenario you will get almost 3, or might be a secondary infection to the lungs. The secondary pneumonia or VAP, this because of PDA up and out, or surfactant given, or all of a sudden rupture of because the expansion is gone out, then pulmonary hemorrhage will occur. If this happen to is a acute deterioration, and it's a catastrophic. If somebody is taking care of a baby, 26-weeker baby, if somebody is a resident is calling the baby discharged, when it come to mind, one thing is this is pulmonary hemorrhage happened to that baby. So that time we have to definitely, even if CPAP or something, it's not going to help because it's a sudden deterioration. Acute deterioration you have to put, even if ventilation we have seen, conventional ventilation going to fail, we put on to HFO. Okay, and we might be giving a surfactant more on site. Secondary surfactant deficiency will be there. So we are giving on surfactant at that time also. So that is a different scenario. When HFNC is failing, CPAP is failing, NIPPV will fail, conventional ventilation is going to also fail. If a massive hemorrhage will be there. Because it's nowhere confined to one area. It will be pulmonary hemorrhage, it's a massive hemorrhage will be there.
So at your center, your primary mode
is HFNC. If it's more than 28 weeker, we normally used to tell the sister, even sisters are very comfortable on that one. Sir, HFNC will put. They normally used to tell us because very friendly. You will just go and use, you will see the complete difference between a CPAP baby and HFNC baby. How the baby will be after 2 weeks or 3 weeks, you will see never cause injury. And the baby are very happy and the mother will be happy because the most of bonnet the parents will see, no, this will be, and they cannot see the baby. Have you seen this one? Even putting the CPAP also, you will see the eyes will get puffiness on the second day because of the pressure effect. It's not because of, and venous return will be not be there. If you put a string strap here, if it has gone to this one, other side, most of the time we will manipulate here because here we are fixing, then it's coming up and down, then second day it will get laxity because the elasticity will go on by 1 or 2 days. Then we will put some plaster, then it will come to the Dynaplast. Then after the Dynaplast will not work, then safety pin will come out. So by end of 1 week, we might have changed the bonnet or might be that cap is completely removed out. Second cap will come to play on second week. Then another cap will be on third week or fourth week. So by the time ending on second or third week, we will might have changed 2 or 3 CPAP. Definitely, if you are putting on CPAP. So this is ideal scenario when putting a CPAP. Even if put a CPAP, RDS baby severe RDS, you put on CPAP. But day by day, you just think of can I switch up to something which is there. This is called HFNC. Like previously, like invasive ventilation, we normally used to change. Can I change to NIV? Can I extubate the baby? Like that, can I change from CPAP to NIV to HFNC? That will be the norm. If you are putting. Yeah, because the innovation is going on. Even other people also like same thing, the delivery room CPAP.
Design perspective, the difference between CPAP and HFNC is this one only.
Expiratory only one limb is there. Here only one limb. And that is delivering the PEEP. That's all.
We don't know exactly how much PEEP is being delivered.
Still you don't know. Once I made so much effort, don't tell like, okay, I don't know how much PEEP. Yeah, exactly. But we are roughly, we can tell if you are giving a 6 PEEP, if I flow of 6 liter for a 1 kilo baby, it delivering 5 to 6. But it might be more or might be less. Nobody knows. Any doubt anything? I think you can, everybody should go and have buy a machine of HFNC. If a CPAP machine is there, simultaneously you can use this one. You are taking out.
Many adults have gone, they will sell now.
Yeah, I think that is there because in my unit also same. It's a super specialty unit, 200 COVID patients. Sir? This one, sir. Airbow, we have 3. We have 3 airbow. This, उसको भी उन लोग भी कम कर देंगे प्राइस because now many people are coming and using, they will definitely go on decreasing the price.
ये क्या करते हैं?
2.8 lakhs. And that is good sir, 2.8 lakhs. इसका कनेक्टर एक बना
अच्छा स्टरलाइज करने के लिए
उसका ये yeah.
So can you all move to the next ventilator part?
The problem because that injury is causing, because you are putting snuggly feet, so sometimes you put more on like on tight enough in the CPAP, no, that nothing is there and it will get that
ಬ್ಯಾಕಪ್ಗಳು ಬರೋ ಬರೋಲ್ಲ ನಮ್ಮ ಬ್ಯಾಟ್ರಿ. ಸರ್ ಸ್ವಲ್ಪ ಸೈಡ್ ಕ್ರಾಸ್ ಆಗಿ ಡೆಮಾನ್ಸ್ಟ್ರೇಷನ್ ಆಗ್ತಾ ಇದೆ ಸರ್, ಗೊತ್ತಾಯ್ತು, ಲೈವ್ ಹೋಗ್ತಾ ಇದೆ. ಹೌದಾ? ಡಾಕ್ಟರ್ಸ್ ಏನಾ ಲೈವ್ ಹೋಗ್ತಾ ಇದೆ, ಸ್ವಲ್ಪ ಕ್ರಾಸ್ ಆಗಿ ನಿಂತ್ಕೊಳ್ಳೋದಿದೆ ಸರ್. ನೀವು ಕಾಲ್ ಮೇಲೆ ಸರ್ ಝೂಮ್ many people are attending this. People are attending Zoom. Taken or not? ಬರ್ತಾ ಇದೆ ಝೂಮ್ ಮೀಟಿಂಗ್ ಅಲ್ಲೇ ಹೋಗ್ತಾ ಇದೆ. ಆ್ಯಂಡ್ ಐ ನೀಡ್ ಆಲ್ ಸೈಡ್ ಆಫ್ ಬರ್ದಿರೋರಿಗೆ ಡಾಕ್ಟರ್ ಮಾಡಿ ನಾಳೆ ಲೈಫ್ ಒಂದಿಲ್ಲ.
सही
Single